Good evening, ladies and gentlemen. All great things comes to a small halt, and today is one such day. Today is day 7, and the brilliant marathon that we all started on an update in lymphoma. Today is the last penultimate finale day. As all of us know, it includes the best of 16th ICML, International Conference on Malignant Lymphoma, Lugano. We had wonderful participation, more than 1,200 plus registration. There were almost 16, 17 countries which participated in very active numbers. We are all grateful to you. A very, very warm welcome to our chief guest, Dr. Sharad Damodar, and a very warm welcome to our program director, none other than Professor Dr. M.B. Agarwal. So the entire program has been managed, conceptualized, and the entire integration of international speaker has been done by you. We're extremely grateful to bring some of the best lectures of all the time to India and so many other countries. No wonder you're called teacher of teachers. We're extremely grateful and thankful to you, sir. May I request you to take it forward from here.
Thank you, Dr. Manoj. Good evening. So the update in lymphoma, including best of 16th ICML, day 7, brought to you by Mumbai Hematology Group, supported by INTAS, managed by Mice Ideas. I'm thankful to Dr. Manoj Kumar and his team from INTAS, Mr. Rajesh, Mr. Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our international guest speakers, our chief guest of the day, Dr. Sharad Damodar, our discussants who are eminent hematologists and medical oncologists, and you participants for sparing your this time Sunday evening. Today, day 7, 19th September, our discussants include Dr. P.K. Jayachandran, Associate Professor, Department of Medical Oncology at Cancer Institute, Adyar, Chennai. Dr. Anant Gokarn, Associate Professor, Department of Medical Oncology, TMC, Mumbai. Dr. Dipanka Bhattacharya, Associate Consultant, Medical Oncology and Hematology, Vedanta Hospital, Lucknow. Dr. Jatin Sarin, Director, Medical Oncology and Hematology, IV Hospital, Mohali, Chandigarh Cancer and Diagnostic Center, Chandigarh. Dr. Rahul Arora, Hematologist and Bone Marrow Transplanter, RST Hospital, Nagpur. Dr. Shilpa Bhartia, Consultant Hematologist, Parkview Super Specialty Hospital, Apollo Hospital, Kolkata. Dr. Roshni Pandey, Consultant Medical Oncologist, Mahakoshal Hospital, Jabalpur. Dr. Aditi Shah, DNB Clinical Hematology, Department of Hematology, Narayan Hridayalaya, Bangalore. And I understand now she has moved to Mumbai. Dr. Ankur Mittal, MBBS, MD, FICH from Nayar Hospital, Mumbai. PDF Clinical Hematology and Bone Marrow Transplant from Tata Memorial Center, Kolkata. Ex-observer at MD Anderson Cancer Center. And now Clinical Hematologist and Bone Marrow Transplant Physician at Mohan Dai Oswal Hospital, Ludhiana. I apologize that I do not have picture and details over here, but we also have Dr. Aditi Thanki from Rajkot with us. She is hematologist and medical oncologist at Rajkot. Our chief guest for the day is Dr. Sharad Damodar. Everyone knows Sharad in this country and all across, virtually everywhere. He's senior consultant hematologist and head department of hematology and transplantation at Majumdar Shah Medical Center, Narayan Health City, Bangalore since 2004. He's clinical director there since 2015. He's vice chairman, Oncology Collegium, Narayan Health Network. He's performed over 1,500 bone marrow transplants till date. He did his MD in internal medicine from St. John's Bangalore, followed by DNB, Internal Medicine, DM in Hematology from CMC Vellore. The recipient of Chairman's Award for Best Doctor in 2015. Recipient of Visiting Training Program Award, awardee for 2015-16 from ASH. Secretary, Karnataka Chapter of ISH meeting. Member multiple committees that devise the guidelines in MSMC. And ex-chairman of the Hospital Transfusion Committee. Member of the Hospital Infection Control Committees. Member of the Hospital Drug Formulary Committee. In charge of the DNB program in clinical hematology. In charge of the postgraduate fellowship program in comprehensive hematology, oncology, and stem cell transplantation. Has published extensively in peer-reviewed international and national journals. I request him to inaugurate our today's webinar and give us some words of wisdom. Thank you.
Thank you so much, sir. It's an honor and my pleasure to actually participate in this webinar, which was initiated a week ago to actually highlight the World Lymphoma Awareness Day, which is celebrated on the 15th of September, and this entire week, which is the Lymphoma Awareness Week. And this time for lymphoma awareness, the theme has been, we can't wait. So there are 3 points which have been highlighted. We can't wait to take care of our own health, considering the pandemic. We can't wait to diagnose and treat the lymphomas. And we can't wait to support people who have this disorder and taking care of them. And I'm just adding one more, we can't wait. That is, we can't wait to learn more about lymphoma. Thanks to Professor IMB Agarwal, who's actually organized this brilliant series of webinars over the week. And today it culminates in this particular session, and it's an honor for me to participate in this. Now, you're getting some of the best speakers from ICML Lugano participating. Earlier days when we could actually physically attend this meeting, it's a wonderful meeting to attend. It's a very scenic place in Switzerland called Lugano. It started way back in 1981 when Professor Franco Cavalli actually initiated it as a group of lymphoma experts who were meeting there. What started off as about 500 people getting together is now capped at 3,500 because of shortage of accommodation in that place. So you can't go beyond that because you can't accommodate more people there. So that's something for the newer people to realize, that if you do get a chance ever, please go and attend the meeting. It's a wonderful meeting. It's a great place to also listen to this. And thanks to this, we have some experts in this field actually giving us this talk. It's a pleasure for me to also know that Dr. Stephen Treon is one of the speakers today. I've had a chance to interact with him, at least through mail, on a common patient we've been discussing. And it's really nice that we'll be able to actually listen to him. And you have more such stalwarts who will actually be talking to you. So from a postgraduate or a student perspective, I think it can't get any better than this to actually have an entire week of a series of webinars with experts in this area talking to you in the field of lymphoma. So with these few words, I'm extremely thankful and grateful to Dr. Agarwal for giving this opportunity and actually organizing this. We never had this kind of thing when we were students. We had to physically go and attend meetings, but I think it's really lucky for the people who can actually listen to this. And I think it's a great session which he's planned out. And I'd like to end with this and thank him for that and formally inaugurate this webinar. Thank you.
Thank you, Sharath, for those kind words, and also for inaugurating the last day of this wonderful series of webinars that we have had. It's now my pleasure to introduce the first speaker. First speaker, Dr. Stephen Treon, today does not require any introduction. He is, if you have anything to do with Waldenstrom macroglobulinemia, then all the credit for all the developments on all the fronts of this particular disease go to him. He was our guest in Mumbai almost half a decade or more, and I have met him in multiple meetings here and there. I was quite surprised that he could remember my face and call me out by my name. So he's a great personality. You have to meet him and you have to speak to him and spend 5 minutes with him to understand what kind of person he is. He's also conducted webinars for us. Very low profile person. You put a mail and he's there for you to accept the invitation. So COVID has brought in a lot of difficulties, but as Dr. Damodar put it, the best thing that has happened is that you have got the best of the information and knowledge coming in your bedroom. And today is one such day when you're going to hear the master of Waldenstrom in next 45 minutes, for next 45 minutes. Just to complete the formalities, he is director, Bing Center for Waldenstrom Macroglobulinemia, Professor, Howard Medical School, Dana-Farber Cancer Institute, Boston. And he's going to speak to us on, of course, his lifetime research work on Waldenstrom macroglobulinemia. Over to sir.
Thank you so much, Professor Agarwal. It's really an honor for me to be able to once again be able to interact with you and to also be able to give this lecture that you've so kindly invited me to give today. And I'm going to try to actually review both what I think is background as well as information that I think the attendees will find useful in terms of their clinical practice, but also their understanding of Waldenstrom's. And I hope you're able to see my slides at this point.
Yes, sir.
But if you're able to, I just wanted to start off with this slide because next year in Madrid, from October 6th to 8th, we will have the International Workshop on Waldenstrom's, number 11 actually. And I hope for many of the attendees who might find today's lecture interesting or have more curiosities about Waldenstrom's that we'll have the pleasure of being able to host you. This will have been a 4-year hiatus because of COVID in having this meeting. But I think with all the wonderful developments and safeguards that are out there, we feel confident that this meeting will go forward. So I was tasked today to give this lecture on Waldenstrom's. I do want to show my disclosures before I start. And I think it's always a good spot to start a lecture like this by talking about Jan Gustav Waldenstrom. He was really an astute physician in his time, and he credits much of the work that he did on Waldenstrom's in his ability to listen to his patients and learn from them. He actually regarded them as his teachers. And I think this is really always a very enviable position to be in because our patients are really our best teachers, and we can learn a lot just by listening. The disease that he first described in 1944 met with quite a bit of resistance. Initially, most folks who had read his paper met it with skepticism. They really didn't think he described a new disorder, that he was just merely speaking about, a variant of multiple myeloma. But as we will, talk today, you will see that he was spot on, that he had made really, this seminal discovery of a new disease. And just to review exactly what is Waldenstrom's, because sometimes you go back in the textbooks and you're not quite sure, these are the diagnostic criteria, and they're really based on the WHO criteria, which have adopted Waldenstrom's as a lymphoplasmacytic lymphoma with bone marrow involvement and IgM monoclonal gammopathy of any concentration. So you merely have to show that the bone marrow has histological involvement of disease and that there's an IgM monoclonal protein present. The level of it is not critical. And you will also see that based on international workshop criteria, that you tend to see a bone marrow infiltration with small lymphocytes, plasmacytoid cells, and plasma cells. So you really have this amalgam of mature B cells all the way to plasma cells constituting the clone. Usually the pattern is that of an interstitial diffuse pattern, but you can see also nodularity. And the typical B cell markers are expressed, including in some cases CD5, CD10, and CD23. So don't be distracted by the diagnosis, because sometimes you see this and you think, well, maybe it's CLL. And based on NCCN guidelines, molecular diagnostic testing is also recommended for MYD88 and CXCR4. We're going to dive into this much more in a little bit. So I already spoke to you about the fact that there, are typical B cell markers, which you will see on the plasma cell population. You will see CD38 and CD138, although the CD38 tends to be dim relative to myeloma. And this is one of the reasons why we believe daratumumab turned out to be such a disappointment for this disease. We were expecting it to be quite active as another plasma cell disorder, but it turned out it didn't. Now, when you look at somebody's IgM level, be advised, you really can't predict how much disease is in the bone marrow. There's really no relationship between the serum IgM levels and the bone marrow involvement. You can see it Here you can have patients who have very little bone marrow involvement of disease, but have very high IgM levels. And conversely, over here, you can have somebody packed with Waldenstrom's that shows very low IgM levels. Now, I'm going to tell you a little bit about this disease. It thrives in the bone marrow. Yes, you do see extramedullary disease, but there's a reason why it's in the bone marrow. And it has to do with the microenvironmental support. And as many of you have seen sometimes in the bone marrow biopsy reports, one of the interesting curiosities is that you see an excess number of mast cells in Waldenstrom patients. This was something that we were fascinated by. We wanted to learn more. You can see here a nodule of Waldenstrom cells surrounded by mast cells. These are actually tryptase stain. That's how we identify them. And here's somebody who has diffuse involvement with lots of mast cells. And what it turns out is that these cells actually express growth-supporting ligands to help the tumor grow. Among them being CD40 ligand, which is one of the most potent ligands for stimulating B cell growth. And so based on these observations, which were actually made in my laboratory, almost now 15 years ago, we were very interested to know how these interactions actually took place. And this, as many of you know, Waldenstrom's is a tumor that's actually derived from memory B cells. And memory B cells universally express CD27. But when you look at the Waldenstrom cells, they tend to be devoid of CD27. Now, why that's the case is that you have these metalloproteinases that are actually cleaving off the CD27 and they're solubilizing it. And you can actually pick up the CD27 levels in the bloodstream. They tend to be sky high in Waldenstrom patients. You don't really see very much elevation in myeloma or other diseases, but in Waldenstrom, it's very high. And soluble CD27 actually binds to its receptor, CD70, on mast cells. And we were able to show this interaction was quite interesting because once CD27 bound to CD70, it upregulated these growth-enhancing ligands. So these mast cells have actually been duped into helping the Waldenstrom cells grow. And of course, there's opportunity here with these discoveries to target this interaction. And we did so in a very nice paper we published in Blood, where we had a mouse xenograft that we modeled, where we treated the mice with SGN70, which is a CD70 blocking antibody. And we were able to show that this actually curtailed growth of the tumor. Now, Waldenstrom's is a fascinating disease because you can have clinic and all day and you'll not see two patients present identically. And that's because there are many manifestations of this disease. Of course, for most patients, it involves a packed bone marrow that can lead to cytopenias, anemia being far more common. In fact, anemia is the reason why we treat Waldenstrom's in about 70 to 80% of times. But anemia is complicated. It's not just because of bone marrow crowding. You see a lot of other mechanisms contributing to the anemia of Waldenstrom's, including the IgM that's made by the tumor contributing to cold agglutinemia. And I'm going to talk a little bit in just a second about hepcidin, which is also a very, very critical factor. Now, IgM excess can, of course, cause hyperviscosity. I know all of you are aware of the symptoms of hyperviscosity that can occur. Usually, this occurs when the IgM is above 60 grams per liter or 6,000 milligrams per deciliter. You also see that the IgM can act as an autoantibody, not only causing cold agglutinins, sometimes it can actually cause cryoglobulins. It can actually bind to the myelin and cause IgM neuropathy. And of course, the light chain can cause amyloidosis. And I think it's also important for our viewers to know that this is a lymphoma. And not unexpectedly, you will see adenopathy, but it tends to be much more uncommon at diagnosis and much more common at relapse. And then lastly, I think to keep in mind and your suspicion level high is when the disease gets into the CNS. You can have patients presenting with all kinds of neuropsychological problems. So always keep in mind that Bing-Neal syndrome, as we refer to CNS involvement by Waldenstrom's, can occur in these patients, sometimes even if it's the presenting symptom for their disease. Now, just a word about hepcidin. It's a fascinating molecule, and it's made even more fascinating in Waldenstrom's. You'll see patients coming in with anemia. You'll work them up. Your workup should also include looking at their iron saturation levels. So get a total iron level get a TIBC and look at their iron saturation, because often it will be low. And the reason for this is that in Waldenstrom's, not only because of the IL-6 environment that's created by the tumor, but also because of MYD88, you actually see an excess of hepcidin production. And what hepcidin does is it actually blocks iron from translocating from the gut. It also causes monocytes and macrophages to take up the iron. So even if you take a bone marrow and you stain it for iron, you're going to see iron there, but pay attention, because the iron is going to be in the monocytes and macrophages. It's not going to be where you want it in those red blood cell precursors. And I point this out to you because even though this may be a high-tech problem, it's a low-tech intervention. Merely giving the patients intravenous iron infusions can overcome this hepcidin blockade. And sometimes we do it with chemotherapy, because we'll see that we're knocking down the tumor burden, but the patients still remain anemic, and it's often, alleviated by giving parenteral iron infusions. So I just want to show you some of the perturbations here, just so you put this all in your mind as to what a Waldenstrom patient might look like. This is somebody presenting with hyperviscosity. The best place to actually work up somebody with hyperviscosity is by looking at their fundus. Take a good clinical history, but look at their fundus. And you'll see often, dilated retinal vessels. You'll also see a lot of hemorrhaging, particularly in the periphery, which is why, not only you should do your exam, but also get an ophthalmologist involved that can dilate the eye, and you can look, particularly in the periphery, for evidence of these hemorrhages. This is somebody presenting with very bad cryoglobulinemia. In fact, his cryoglobulin is precipitated even at room temperature, and you can see that this causes a profound acrocyanosis. In this case, plasmapheresis was used very carefully, because you had to put warmers on both sides of the machine to make sure that you were not, cooling down the blood accidentally. And what you see here is that just by merely removing the IgM, you could restore blood flow. Now, peripheral neuropathy is a big problem in Waldenstrom's. Usually it's a sensory demyelinating neuropathy. It can happen in about 20 to 25% of all patients. And these days, actually, it's the neurologist referring to us most commonly, because they're doing SPEPs as part of their routine. And what you see as a result of the IgM being made by the tumor, the monoclonal IgM, is it binds to the myelin. These are all nerves cut in cross-section and counterstained with IgM. And you see that basically it binds to the myelin sheath. The nerve is right here in the middle, and this causes a, immunological destruction to occur, usually mediated by complement, but also by effector cells that just strip away at the myelin. You can also see amyloid-related neuropathy. When you do EMG studies, which you should do in all of these patients, you'll usually see a demyelinating pattern with the IgM related neuropathies, but with amyloid, it's usually axonal degeneration. So the nerve itself is dying as a result of the amyloid deposition. Now, depending on which one of these kind of neuropathies you have, is impacted by, how the patient will do. So if you're treating patients who have IgM neuropathy, IgM demyelinating neuropathy, they're more likely to do better in terms of response than somebody who might have amyloid. Usually, if you treat them sooner into the course of their peripheral neuropathy, they'll do better. If you tend to treat them, with more aggressive therapy, and this actually is a study that predated some of the drugs we'll talk about today, but I think what was important is that the deeper responses translated into greater improvement for these patients. Now, not everybody needs to be treated who has Waldenstrom's. Recognize that about 30% of all patients may in fact have what we call asymptomatic disease. In the old days, we used to use the word smoldering. There are now guidelines, including the NCCN guidelines, that exist for when to start therapy. So just keep in mind that there are guidelines out there that give us guidance in terms of when to start therapy. Otherwise, watch and wait is appropriate. And in fact, Jan Waldenstrom would tell us, let well do, meaning that, if somebody's not symptomatic or doesn't have, numbers that are going to worry you, then it's fair game to treat. The only thing I just want to caution you on is the IgM. There isn't really a preset IgM level for when to treat, because you can have people who are asymptomatic even at high IgM levels. But in general, in our practice, we start therapy even if somebody crosses the 6,000 milligram per deciliter mark. And that's because the likelihood of having hyperviscosity related injury goes up dramatically when your IgM is that high. So we don't let somebody, fall off the cliff before we give them a helping hand. We tend to start therapy sooner. We usually use a hemoglobin of less than 10 on the basis of the disease, or a platelet count of less than 100,000 to start therapy. And of course, if they're symptomatic because of neuropathy or cold agglutinins or cryoglobulins or other problems such as amyloid, then I think it's fair game to treat. Otherwise, let well do. Now, I'm going to talk a little bit quickly about conventional therapy, which includes rituximab, either alone or in combination. I think the thing to come away and recognize is that with combinations, we've seen much higher overall responses, even deeper responses, although don't be fooled here. I have here VGPR/CR. It's very rare that we get patients into CR. So the goal of therapy is to eliminate symptoms. It's not to get people to CR. So keep that in mind, because many times these patients tend to be overtreated when in fact, a clinician might think that that might be the end all. Now, thalidomide, cyclophosphamide, nucleoside analogs, proteasome inhibitors, bendamustine, all have been tried with rituximab. And you do see these higher response rates. These days, more and more, we focus our therapy on either proteasome inhibitor combinations or bendamustine when we're using combination therapy with Rituxan. And that's because over time we've learned about each of these drugs and the relative toxicity they may offer. And with these combinations, particularly proteasome inhibitors and bendamustine, it's not uncommon to get somebody into a remission from somewhere from between 4 and 6 years in the frontline setting. Be careful of Rituxan. One of the things that it can do is cause this flare. In fact, we were the first to describe this. It's a very interesting phenomenon that's actually triggered by bystander cells reacting to the Rituxan and making IL-6 that then drives the tumor to make more IgM. On any particular day, you can give somebody their first dose of Rituxan and go back that afternoon, you'll see that their IgM may have doubled or tripled. It's really that fast that can happen. So if the IgM is high, keep in mind that, you don't want to give them rituximab right off the bat. In fact, if it's more than 4,000 milligrams per deciliter, you might throw them into a hyperviscosity crisis. And also keep in mind that the things that can go wrong with IgM in these patients, be it neuropathy, cryoglobulins, or cold agglutinins, can get worse if their IgM, spikes. And so in that case, consider plasmapheresis to get the IgM back down and alleviate these, the collateral problems associated with the IgM. And in general, our practice is that if an IgM level is above 4,000 milligrams per deciliter or 40 grams per liter, it's better to maybe start with the chemotherapy first without the Rituxan and then introduce the Rituxan, or consider plasmapheresis. Of course, I'm going to talk to you about some newer drugs today where this becomes less of an issue. Cyclophosphamide-based therapy used to be, I think, one of the important darlings of treating Waldenstrom's in the past. I think bendamustine has largely replaced it because most of the randomized data that I'll show you in a second seems to suggest benda is better than cyclophosphamide-based therapy. And you really shouldn't be using CHOP in any way. Don't use adriamycin or vincristine. You don't need it. We showed that many years ago. And so if you're going to be using cyclophosphamide, usually it's the CDR or DRC, depending on how you want to scramble the acronyms, that's usually used. So either cyclophosphamide, dex, and rituximab together. The responses occur in about 80% of patients, and the benefit with a median PFS of 3 years is kind of modest compared to what you see with a lot of other therapies we'll talk about today. This is the important Rummel study many years ago that pitted bendamustine versus R-CHOP, just to give you a comparison against cyclophosphamide-based therapy and to recognize that patients did better in terms of a longer progression-free survival with bendamustine-based therapy versus R-CHOP. And the one word about bendamustine, you really don't need 6 cycles. In most of these patients, 4 cycles is ample. And of course, dose reduce in the older population of those with renal problems. Nucleoside analogs also were very important in the past for treating Waldenstrom's, except we saw a lot of secondary malignancies, particularly myelodysplasia and acute leukemia. So we tend to now sideline the use of nucleoside analogs like fludarabine and cladribine. However, it may have a role in CNS disease like Bing-Neill syndrome. I will show you that ibrutinib is probably a lot better, but keep in mind, as a good salvage, the use of fludarabine in particular, because it has good penetration of the CNS, can be a benefit in some of these patients. Proteasome inhibitors have also been very important in the past for treating Waldenstrom's. Now, again, because of the newer pharmacotherapy, I'll show you, they've been relegated to the side. Even though you can get really good durability and responses with proteasome inhibitors, the problem is you also get a lot of neuropathy, including grade 3 neuropathy with bortezomib that leads to very frequent discontinuation of therapy. With carfilzomib, you don't really see the more significant neuropathy, but of course there is in the back of our heads always concern for cardiomyopathy. But I did find carfilzomib when I ran that trial to be a very, very good drug. Maintenance rituximab always comes up as a question when you're thinking about, using rituximab combinations. This is a study that I published back in 2011, showing, in fact, it was an observational study where we looked at patients who received Rituxan maintenance versus observation. And these were very matched populations of patients at the time. And what we saw was that PFS could be extended by almost 2 years with the use of maintenance rituximab, usually one infusion every 3 months for 2 years' time. And there was also in this study a hint towards overall survival benefit, as shown here. Now, a prospective study that was reported at ASH 19, and still we're waiting for Dr. Rummel to publish this very important paper, came from the German group. And here they did something very different. In our study that I just showed you, we looked at people that had minor responses or better for a trigger to start maintenance rituximab. Here in this study, they used major responses. So you had to really be a winner to go into this pool. And here you got bendamustine Rituxan, and if you were a winner once again, had at least a partial response, you got randomized to get more Rituxan as part of a maintenance strategy. Here, one infusion every 2 months for 2 years, or watch and wait. And what was interesting here is, again, picking the winners, not much of a difference if you took the whole population into account, but the older population, over 65, seemed to have this advantage in terms of progression-free survival. So keep in mind, again, these were patients that already had a major response. If you're thinking about maintenance rituximab, this is, I think, a reasonable population to treat, or somebody who may have, a minor response and you just want to be able to get more traction. Rituxan is not always your friend for so many reasons, because it can also potentiate hypogammaglobulinemia. And many times then you end up with the problem of, then needing to give the patients IVIG. Don't give IVIG and Rituxan, you should just stop the Rituxan at that point, because IVIG competes for the same receptors as rituximab. Now, I'm going to bring you now into the 21st century. In fact, I'll bring you into the 2020s by first telling you one of the most important seminal, I think, steps forward for this disease was the discovery of the MYD88 mutation. Up to 97% of the patients have this mutation. It usually involves a mutation where leucine at position 265 becomes proline. This is a very important event because proline is a amino acid that actually, is very rigid, so it distorts protein configuration. So if you ever see a proline substitution, it means something, it's functional. As I mentioned, you see it in over, almost now 95, 97% of patients. It can help you in terms of distinguishing Waldenstrom's from other IgM producing malignancies, including multiple myeloma. No myelomas have this mutation. What's been very important is all the work that's gone into deciphering exactly what MYD88 does. And this was largely accomplished in our laboratory. I'm very proud to say, because Dr. Guang Yang, as well as Dr. Xia Lu and her son here, painstakingly spent a lot of time doing these models. And MYD88 itself is an adapter protein for toll receptors that actually are sensors for infection on these immune cells. But if you have the mutation in MYD88, it's actually like turning a switch on and making, and breaking it in the on position. So this turns on a very elaborate cascade of downstream pro-survival signaling proteins, including HCK. This is a SRC family member, and it has no business being in a late stage B cell. You see it in early B cell ontogeny, not late stage. So when this is turned on, you can see it's like a octopus, it turns on a lot of growth survival pathways, including Bruton's tyrosine kinase, which I'm going to talk to you about. And also to recognize that ERK is turned on. You may not be familiar with ERK, but this is actually a driver of cytokine production. So this is where we think the IL-6 comes from. And this, of course, not only auto-activates the cell, but it can also feed into the microenvironment. And with this kind of deciphering, I think the thing to also come away with is look at all the therapeutic opportunities we now have, including, of course, targeting BTK that we'll talk about with all these very exciting BTK inhibitors, but also HCK. We have been developing new molecules that go after HCK. HCK also transactivates the BCR pathway. And of course, there's a lot of pharmacotherapy against SEEK. And so I think the nice thing about this is we have a playbook here that's going to be very important to us for years to come. Now, the second most important mutation in Waldenstrom's was also discovered in my laboratory, thanks to the genius of Zachary Hunter. He's a bioinformatician and biologist who actually went back, created new algorithms for studying the whole genome. Given the same data field, he came up with this discovery. And this is kind of interesting because you probably know that there are CXCR4 mutations in the germline of patients with this syndrome called WHIM syndrome. But in Waldenstrom's, pretty uniquely, it's in the Waldenstrom cells themselves. And usually these mutations occur here in the C-terminal domain. This is an important regulatory part of the molecule. I think many of you know that CXCR4 binds to CXCL12, which is made in the bone marrow stroma. And this actually auto-activates the CXCR4. But the patients can have two different brands of mutations. One brand is the nonsense mutations, about half of them do, where you introduce a stop codon, the most common of which is this S338X mutation. The X means a stop codon's been introduced. So you lose everything after that. And you also have frameshift mutations where you introduce or delete DNA that actually scrambles the code. This area is very important because this is where, once you get activation of CXCR4, this is where you get these molecules called arrestins that come in and bind this region and then shut down the signaling cascade. But if you're missing that pigtail, you can't shut things down. Now, I want you to also come away understanding that nonsense CXCR4 mutations are worse because they're the ones that are associated with hyperviscosity crisis, high IgM level, high bone marrow involvement, and they tend to be less sensitive to BTK inhibitors that we're going to talk about in just a second. And in fact, you can see this here in the nice data that Dr. Castillo from our group published, along with Dr. Gustine here, showing that the people that had the CXCR4 nonsense mutation showed, quicker progression. And also, when you looked at these CXCR4 nonsense mutations, clonality played a role. Usually CXCR4 is a subclonal mutation, but if you have a high clonal penetration within the tumor, greater than 25% of the cells actually having this CXCR4 nonsense mutation, again, they're more likely to progress on a drug like ibrutinib. So this kind of wraps up for you sort of our thinking around CXCR4. It's made by the bone marrow stroma. It acts as a chemoattractant, one of the reasons why these cells love to go to the bone marrow. And also to recognize that we now have drugs that can block CXCR4. I'm going to come back and talk to you about some of these exciting advancements. Based on the discovery of BTK being very important in the mid-88 cascade, we were the first to actually do a clinical trial looking at ibrutinib in symptomatic previously treated patients. The first paper came out in the New England Journal in 2015. This update just came out in JCO. And what did we learn? Well, these were heavily pretreated patients, first of all. They had a median of 2 prior therapies. Some had out to 9. 40% were refractory to their previous therapy. And despite that, with this longer follow-up, you can see here, overall response rate, 90%. We call somebody as an overall responder if they've had at least a 25% reduction in their IgM, so a minor response or better. 80% had a major response, meaning 50% reduction in their IgM. And very good PRs occurred in 30% of patients. This is when you see a 90% reduction in the IgM as a marker of disease. And so what we also learned is the genomics played a big role. If you had no MYD88 mutation, guess what? No major responses. That's not a surprise. But if you had, the MYD88 mutation alone, you did better than if you had both mutations. And again, this is based on in vitro modeling where we know that CXCR4 contributes to drug resistance against BTK inhibitors. But look at here the difference in VGPR, a five-fold difference, five-fold less patients got to a VGPR if they had MYD88 and CXCR4 mutation. And it also took them longer to get to a major response, almost by a few months' time. In addition, when you look at the updated progression-free survival curve, you're going to come away with some very, very positive results. You're going to see that we didn't hit the median PFS at 5 years, but we were close, but that 87% of the patients were still alive. Again, considering heavily pretreated population of patients, this is remarkable. And here too, recognize that progression-free survival was impacted by the genomic subgroup. Now, one of the concerns, of course, with this, with ibrutinib is atrial fibrillation. We did see over time, our AFib rate went up from 5% that we originally reported with a median follow-up of about 2 years up to 13%. However, most of these patients still continued on ibrutinib with medical management. We also just updated our frontline ibrutinib monotherapy study. This was originally reported in JCO. My colleague, Dr. Castillo, just updated this in leukemia. 4-year progression-free survival is 76%. And you see, once again, a difference between those that are CXCR4 mutated, right here at 59%, versus the CXCR4 wild-type patients, 92%. Everybody was MYD88 mutated in this trial. Now, the INNOVATE trial also has been just accepted now for publication. Dr. Garcia Sanz updated this at last EHA. This was an important trial because patients were given either ibrutinib Rituxan or randomized to placebo Rituxan. And what we learned here is across all the genomic subgroups, the patients did better, including MYD88 wild type. I want to come back to that. And they did better whether they were previously untreated or previously treated by getting the combination of ibrutinib and Rituxan over placebo plus Rituxan. There was an acceleration towards earlier response by adding in the Rituxan among the CXCR4 mutated patients. Now, what we saw in this trial was much what we had already learned. CXCR4 mutated patients showed earlier progression, even though as a group, ibrutinib Rituxan had better progression-free survival than placebo plus Rituxan. But this wild type phenomenon, where you saw this, extraordinary response surprised us. And I think at the end of the day, it has to do with testing for MYD88. In fact, here, next generation sequencing was used to determine MYD88 status in this trial, whereas in the previous trials that I showed you, the PCR technology was used along with selected bone marrow cells. And so you had much greater sensitivity for picking up the MYD88 mutation. I think this is true because you see, this is the MYD88 wild type PFS curves. See this rapid drop here? This probably is the real MYD88 wild type patients, much like we saw in our trial. So to actually put this to the test, we just published 2 papers back to back, looking at the challenges of MYD88 and CXCR4 detection in Waldenstrom's and comparing next generation sequencing, which is often used by clinical laboratories because you don't have the time to do, B cell selection, but you can have the time to do PCR. So I just want you to compare these two and just see it here, that if you're using NGS, your sensitivity is 66%. So you're going to be missing 1 in 3 patients who really have the MYD88 mutation. And usually the false negatives are among people who have very low bone marrow disease, as we can see here in this study. With CXCR4, it's actually worse. You're missing 2 out of 3 that really have the CXCR4 mutation. And again, it tends to be in those with low bone marrow involvement and also low clonality for the CXCR4 mutation itself. So these days we're actually we're looking at cell-free DNA technology. And in fact, what's very exciting is for both MYD88, L265P, and even the nonsense mutations, such as CXCR4, S338X, which you can pick up by PCR, you see that the sensitivities aren't actually too bad. And so this may very well come to replace our current gold standard of, doing bone marrow biopsies to read out these mutations. I mentioned to you earlier Bing-Neill syndrome. I just want to make a point that ibrutinib is very effective at treating Bing-Neill syndrome, particularly if you use the higher dose of 560 once a day. You get very good CNS penetration and very nice, long enduring activity. Now, a few words about the other BTK inhibitors. First off, recognize that, there are the covalent BTK inhibitors I'm going to talk about now. These all bind to cysteine 481 on BTK. This is a covalent bond that's formed. But each one of these, BTK inhibitors, including acalabrutinib, zanubrutinib, now tirabrutinib, which is being developed in Japan and is very active in Waldenstrom patients, you see have different kinase profiles. This is the kinome inhibition, plots for these drugs. And whenever you see a red blotch here, and the bigger the red blotch is, it shows you that you're actually hitting off targets. And this is why you really have to look at each one of these drugs in patients to determine what kind of side effect profile might be generated. And that matter also, some of these blotches are good. Like HCK is actually inhibited by ibrutinib as well as zanubrutinib, which you saw in the cascade I showed you earlier as part of the mediated signaling cascade. So what do we learn in all these studies that have been read out in the last year or two? Well, they're all active. Every one of these BTK inhibitors I showed you. In fact, their level of activity is almost identical. It's about 90%. And when you look at the progression-free survival, almost identical. You see about 2-year PFS on average being about 90%. And of course, it drops down over time. The side effect profile can be a little different. With acalabrutinib, you tend to see headaches, at least initially on, and then they dissipate. Atrial fibrillation at the 2-year mark was 5%, which is exactly where it was for ibrutinib. So longer follow-up will be required to see what happens with acala-related atrial fibrillation. Of course, the big story in the last year has been zanubrutinib. This drug just got approved in the United States. So it becomes our second ever approved drug in Waldenstrom's, that of, following ibrutinib. And this was a head-on trial run by Constantine Tam and others where 2 cohorts, MYD88 mutated and MYD88 wild type, patients without the MYD88 mutation, were entered onto the study. Those that were MYD88 mutated randomized to either get zanubrutinib, which is given twice daily, 160 BID, versus ibrutinib once a day. And here, the patients got, if they had the MYD88 wild type, they got zanubrutinib, twice a day. I'm really going to focus today on the cohort 1. Cohort 2 did show activity for zanubrutinib in about half of all patients. But again, there may have been MYD88 testing issues here too, because some of these patients had no bone marrow involvement that were entered onto the study. So I think MYD88 might have been missed in a lot of these patients as well. So what did we learn? Well, numerically, the major response rate was identical between ibrutinib and zanubrutinib. Numerically, there was also a slightly higher VGPR rate, the significance of which we don't know today. What does more VGPRs mean in terms of clinical benefit? Those patients that were CXCR4 mutated, regardless of what arm they were on, had fewer VGPRs. If regardless of whether you got zanubrutinib or ibrutinib, if you were CXCR4 mutated, you saw fewer VGPRs than those patients that were wild type. So again, showing us that CXCR4 is going to be a role player in any of these BTK inhibitors. The big news, however, and what supported zanubrutinib's approval is the differences in side effect profile. Less atrial fibrillation, less diarrhea, less bleeding, but conversely more neutropenia, more GCSF usage. But the infection profile, was comparable to what was seen with ibrutinib. And so I think the way to look at these drugs is, you're going to have to really try to understand your patient. You have to think about, convenience, and you have to think about, adherence. Sometimes it's better in older patients, getting a once-a-day drug like ibrutinib over zanubrutinib twice a day. But on the other hand, in older patients where you might have a concern over AFib, you may be better with zanubrutinib. If you have somebody with cytopenias, you may prioritize ibrutinib because, you see much less neutropenia. And keep in mind, we have more data with Bing-Neill syndrome with ibrutinib. We lack that with zanubrutinib. We know that there is some activity for zanubrutinib in MYD88 wild type. So these are the things you're going to have to really get a hold of in making decisions around which one of these BTK inhibitors to use. Now, I want to talk a little bit about BCL2 inhibition. BCL2 levels are high, particularly in MYD88 mutated Waldenstrom patients. What we do know from studies that we were the first to ever publish on the importance of BCL2 with ibrutinib is that if you add venetoclax to ibrutinib, you can actually potentiate more apoptosis regardless of the CXCR4 mutation status. And so this is one of the reasons why we went forward with doing this very exciting trial with venetoclax in previously treated patients. This was run by my colleague Jorge Castillo. We saw activity across patients, whether they had seen a BTK inhibitor or not, and whether they were CXCR4 mutated or not, with an overall response rate of 84%, major response rate 81%, and look at this, median PFS of 30 months. And so this actually does show us that venetoclax is going to be also very important in the treatment of Waldenstrom's macroglobulinemia. In these days, we're actually focusing on this combination using ibrutinib with venetoclax. We're starting this trial, or we're actually doing this trial in treatment-naive patients. It's almost fully enrolled, but the patients will get 2 years of total treatment with the two drugs, and then all therapy stops and the patients are then observed. Now, we just published this paper in Blood, just came out, using the CXCR4 antagonist ulocuplimab along with ibrutinib in CXCR4 mutated patients. Here, the patients got about 6 months of ulocuplimab, first, weekly for the first month, and then biweekly for the next 5 months, and then drug was stopped, and they got ibrutinib right through here and continued on ibrutinib afterwards. What did we learn? Well, you can get much quicker responses, even VGPRs in these patients who get ulo along with ibrutinib much sooner than you would see with ibrutinib alone. But also more excitingly, their PFS curves now begin to look like CXCR4 wild type patients. So 2-year, 90% estimation for progression-free survival. Unfortunately, ulocuplimab has been discontinued by BMS for development, and that's because they had a not exciting signal in myeloma and AML, which was where they were pinning their hopes. So these days, we're actually focusing our efforts on movarexafor, our oral antagonist of CXCR4, and we're very excited by some of the preliminary data. It's safe to give the combination together. And we'll need to see actually in the next trials the exact readout of what kind of benefit, since this is a phase 1 trial. Now, also, I want to talk a little bit about non-covalent BTK inhibitors. These are inhibitors that bind to other parts of BTK. The one that's actually most advanced right now is pirtobrutinib. You might know it as LOXO 305. Michael Wang, a very good friend of mine at MD Anderson, did this very exciting trial in previously treated patients with MCL, Waldenstrom, and other non-Hodgkin's lymphomas. And just to concentrate on his Waldenstrom patient population, these were people that all had seen already a covalent BTK inhibitor, and yet despite that, he saw very high, response rates, including deep responses in these patients. So we are excited by this data, and in fact, my colleagues Jorge Castillo and Shayna Sorosiak are actually running this very exciting trial of pirtobrutinib in Waldenstrom's at our institution, and this will be also a multi-center study. I just want to conclude here by talking a little bit about how you can use genomic information. I think what's exciting about Waldenstrom's is that we now have the ability to kind of personalize our care. If you have somebody who you encounter who's symptomatic, you might want to prioritize a BTK inhibitor in the first line setting if they have only the MYD88 mutation, because we're seeing this very, very long progression-free survival. They're relatively safe compared to some of the problems we see with other drugs. But if you don't have access to BTK inhibitors, then you can consider bendamustine or proteasome inhibitor-based therapy. Of course, keep in mind, add the Rituxan, only if it's safe and the IgM is under 4,000, and keep an eye on that IgM. If the patients are double mutated, some of them, as I mentioned to you, the ones that are, nonsense CXCR4 mutated, they may have hyperviscosity, and need, immediate, reduction in their IgM. So of course, you're going to plasmapherese them, but afterwards, you might want to think about bendamustine or proteasome inhibitor-based therapy because you want a quicker response. You don't want to be waiting 7 months to get a response to ibrutinib. And again, the caveat, be careful of the Rituxan. Even after pheresis, you can actually sometimes spike them back into hyperviscosity. So you want to keep an eye on how their IgM levels are doing. But if you don't need a rapid response, then a BTK inhibitor with Rituxan might be appropriate because, again, we saw that there was a truncation in the time to get to a major response. And if they're MYD88 wild type, typically we use bendamustine or proteasome inhibitor-based therapy because we don't see activity with ibrutinib. I think zanubrutinib can now be added based on the data that we have seen. And you can also, for patients getting chemoimmunotherapy, think about maintenance Rituxan. I do also want to make the bullet points that we tend to prioritize bendamustine for patients that have bulky extramedullary disease or bulky adenopathy. And we tend to prioritize proteasome inhibitors if they have symptomatic amyloidosis. And if they do have amyloidosis, consider autotransplant as consolidation therapy. For those with peripheral neuropathy, depending on the severity and pace of their neuropathy, either Rituxan alone or with ibrutinib, if they're MYD88 mutated, or with bendamustine, can be considered. And you can find these recommendations actually in JCO. We published them last year as part of this paper. In previously treated patients, I think the thing to keep in mind is we use a very similar algorithm. We tend to prioritize a BTK inhibitor if they haven't seen one in first or second relapse. And now know that venetoclax is also an option beyond, the treatment of, with a BTK inhibitor. Nucleoside analogs we tend to avoid in younger patients because of secondary malignancy risk, and also in people who may be candidates for autotransplant. And keep in mind, autotransplant does have a role, but it's a very limited role. This is not myeloma. You can think about it in patients with multiple relapses, but they have to also have chemosensitive disease. Otherwise, in chemorefractory disease, you shouldn't really be using autotransplant. And with that, Dr. Agarwal, I'm going to stop and happy to take questions.
Thank you so much, Professor Trion. Wonderful update. Enjoyed listening. Before I ask my panelists, and I request them to open their videos, we'll have an interactive session. We also have questions from the audience. I wanted to ask one question to you, whether you will prefer ibrutinib as an upfront treatment over bendamustine or proteasome-based therapy in future, or you're already doing it now?
Yeah, so we tend to prioritize ibrutinib up front. And in aggregate, we tend to prefer it because of the relative safety profile and the long-term suppression of disease. So, this is our concern. I think after you've had a couple of patients develop acute, AML or MDS after bendamustine, you become a little stigmatized. I particularly tend to prioritize it in younger patients where we don't want this problem. But I do think, bendamustine is a very effective drug. We shouldn't discount that. We tend to limit, our administration to 4 cycles. And as I mentioned earlier, dose adjust for the older patient or somebody with, renal pathology for sure. But we do use bendamustine quite a bit. It's usually for people that have bulky disease where you want to see, reduction. And I think you can get a much better reduction with bendamustine than you would with a BTK inhibitor. And proteasome inhibitors have no role with extramedullary disease. They're good at knocking down, the paraprotein, but they have a very modest effect on extramedullary disease.
If CXCR4 is wild type, will you still use rituximab with ibrutinib, or ibrutinib alone is good enough?
That's a great question. Yes, monotherapy only, because they do just as well without needing to add the Rituxan. Exactly. Unfortunately, the Innovate trial didn't include that other very important arm. They should have had, a third arm. But it was a regulatory trial. It was really meant to get the drug approved in Europe, and the standard there was Rituxan, and they wanted the quickest and fastest readout. So this is why the trial didn't have that third arm. It was really a regulatory trial at the end of the day.
Is there any data if ibrutinib starts failing and you use now bendamustine rituximab, what is the efficacy?
Say again? Bendamustine
rituximab as a second-line therapy after BTK inhibitors upfront.
Yeah, very active, very active. In fact, you're going to see response rates and durability that I think, would be very close to what you would expect with frontline. Bendamustine is really always a good salvage drug, which is why I think sequencing a BTK inhibitor first, followed by, salvage with bendamustine, makes sense. In a younger patient, we're trying to change that algorithm by seeing if we can potentiate BTK inhibitors even further. I think by using non-covalents, like pirtobrutinib, we'll have the ability to continue to extend BTK inhibitor usage, and again, minimize an assault on stem cells and decrease the risk of myelodysplasia or acute leukemia.
Thank you. So we'll have questions from our faculty here. Dr. Roshni. Unmute yourself, Roshni. No, we can't hear you. You're still muted.
Now?
Yeah, now we can hear you.
Good evening, sir. How do we follow up these patients? What is the frequency of follow-up? And at relapse, do we need to do the mutations each time? Or if the gap between the first treatment and the relapse is long, can we presume that it was the previous phenotype?
Yeah, it's a great question. If you have determined the MYD88 status and CXCR4 status up front, these are stable mutations, so they're going to exist in the clone, even with subsequent biopsies. So we've been doing this for a long time. We've yet to see in a patient that with CXCR4 wild type at baseline become mutated. So these are relatively stable mutations. So if you have the data on a patient, you don't need to repeat the molecular diagnostic testing.
And the second question was on follow-up. I mean, do we follow up the frequency depending on the IgM levels, or?
Well, the follow-up is a little bit more centered around individual patient care. Like, for instance, somebody who you are seeing for the first time, and they come in, say, with an IgM of 5,000 or 50 grams per liter, and they're asymptomatic, let's say, but they have a high IgM level, and in the back of your head, you're going to be worried more about them, right? So somebody like that, I probably would bring back in another 2 months, check it again. Maybe for the first year, I might see them at a frequency of every 2 to 3 months. And if I see that their IgM is stable after a year, I might, decrease the frequency of visits. So I think it has a lot to do with what your perception, and worry is. If it's somebody with a low IgM, they were incidentally diagnosed, and you brought them in 3 months later, their IgM is stable, then you might be able to get away with every 6 months, seeing these patients. In people that you've treated, depending on the therapy, I usually like to see my patients, every 3 months. But if they've been in long-term remissions, then it's every 6 months' time.
Thank you.
Dr. Anand.
Thank you, Dr. Trion, for the excellent talk. My question is that when do you harvest stem cells and cryopreserve them for these patients? I mean, many of them, if they receive a lot of bendamustine, collecting stem cells or fludarabine, collecting stem cells later would be difficult. So, and considering that most of these patients may not require a transplant, when do you counsel them for a harvest and cryopreserve? Does it depend on the mutation status of the patient?
So I'm going to have to show my hand here. We don't cryopreserve anyone. meaning their stem cells. And almost never do we do auto transplants. Almost never. The few times we use auto transplants is in folks that present with amyloid involvement, because there I think you really got to do your best to squash out, the clone. But aside from that, Dr. Gokam, we don't harvest stem cells. We don't collect them. We don't put them in the refrigerator because there's always spacing issues. There's insurance coverage issues. And the pharmacotherapy is so good for Waldenstrom now. You should expect, a long, life for these patients on average. I'm not saying everyone, but, when I came into this disease some 25 years ago, our, survival was 3 to 5 years. Now, with the new pharmacotherapy, it's somewhere between 18 to 20 years for median overall survival. And it's really been two things that have made this possible. One, the new drugs being developed that are more and more targeted, but two, getting away from the old drugs, because I can't tell you how many people we lost because of the toxicities, short and long term, with older pharmacotherapy that we used to use. And auto transplants, to me, are also not benign either. When you look at the EBMT data, non-relapse mortality, goes up, It's even worse if you're thinking about, allo or mini allo. So for this reason, at least in this disease, thankfully, we've moved away from auto transplant, except with the footnote of those that have symptomatic amyloid. Those you should really consider for auto transplant in this era.
Thank you. Dr. Jayachandran.
Dr. Trion, the lecture was excellent. So I have a question. In a patient with Bing-Neal syndrome, do you consider you were mentioning that the combination of the Tuxan with the bendamustine is not that effective enough. So we do had a same experience patient. Would you prefer to give first line BTK inhibitors or nucleoside inhibitors in that case?
Yeah, great question. So in Bing-Neal syndrome, our best experience comes with BTK inhibitors, specifically ibrutinib, because we don't have really any data on zanubrutinib and Waldenstrom. There have been some anecdotal reports in CLL and MCL patients with CNS involvement, but with Waldenstrom's very, very good data. We even published a very large series in Blood. I would prioritize that. 560 once a day would be my recommendation for the vast majority of patients. Although if you have somebody who's elderly and thin to the bones, you might not want to go 560. So even 420 tends to be very effective in many of these patients. But I would prioritize that, and then I would keep fludarabine in mind as a option in the relapsed refractory setting if they show progression of their Bing-Neal.
Thank you. Dr. Rahul.
Thank you, sir. Thank you for an excellent presentation. So I would like to know if you mentioned in your lecture that CD27 levels are very high during the initial workup. Can CD27 levels be? Can we monitor them and use them as like if the patient achieve remission enough, or can that be level be used as a follow-up marker?
Yeah, great question. And the answer is yes. Soluble CD27 levels parallel IgM. Now, the practice, and in some cases, it might be helpful because let's say somebody you give Rituxan and they flare. The soluble CD27 levels will actually remain more faithful to the underlying disease than the IgM might. But here's the practical problem. It's very hard to test for soluble CD27 commercially. I mean, when we have IgM that's such a cheap, fast, reproducible marker, I mean, I can get my IgM results back in a few hours, at my institution. Being able to advocate for soluble CD27 becomes harder. And believe me, we established the science very nicely. It's an awesome, faithful marker of disease. It's just not practical in terms of, the real world experience.
Thank you, sir.
One question from the audience. Sorry, Dr. Jatin, your question.
Thank you, sir. And it was a most enlightening lecture on Waldenstrom I've ever heard in my life. Sir, this is a practical question. Suppose a 80-year-old guy, patient, started on a BTK inhibitor as a frontline therapy, and he develops worsening cytopenias after 2-3 months. I mean, what do we conclude out of it? I mean, it's whether they are not effective or there is a need to add something to it, whatever. I mean, what to conclude out of it?
Yeah, no, that's a wonderful question. Of course, the answer is very, individual. I will say cytopenias with ibrutinib are very uncommon if it's first-line therapy. In the relapsed refractory setting, you will see the cytopenias. Usually it's because of the sins of the prior therapy, thrombocytopenia being the most common. And so in the frontline setting, the expectation is that it's probably, not related to the drug itself. Although keep in mind, you can have an effect on platelet function, which is why we're always concerned about making sure if you're giving ibrutinib, don't give it with, an anticoagulant if you can avoid it, or even aspirin, because you might, in fact, provoke bleeding risk. So if you're seeing somebody's counts deteriorating, the more likely explanation is going to be that, there's disease progression, and sometimes it's not a surprise. You might want to look at the underlying bone marrow to make sure that this is in fact the case, that this is not, from the drug, or hold the drug and, try to sort out if it's the drug that's contributing. Because sometimes you can have these odd effects with ibrutinib. You can think about dose reducing if that's the case. But I think it really comes down to the individual patient trying to get a better sense of what exactly is going on, what the timetable is. I wouldn't expect somebody's counts to tank in the first couple of weeks on the disease itself. Usually it's a slow moving disease. So I might think more about the drug being etiological. So those are the kind of thinking that I think we need to do when we're looking at these kinds of developments.
Thank you, sir.
Now, a couple of questions from the audience. There's one question whether you can do the mutational analysis from peripheral blood, and is it as sensitive as the bone marrow?
Absolutely. In fact, if they're newly diagnosed, where usually they have a good, a circulating disease burden, you can test for MYD88 on peripheral blood. It tends to be much higher if you isolate the B cells and test with ASPCR, but you can take even mononuclear cells and test. We did publish that paper in leukemia many years ago. Dr. Lian Zhu was the first author in our group. So you can do that. In addition to, as I said, now with cell-free DNA, it's becoming, also feasible to just, take plasma and test for, but that requires cell-free DNA. It's easy, but you got to have the right tubes and you got to process the samples, in a certain way. Whereas, most of our clinical labs are equipped for just taking mononuclear cells from the periphery and testing.
Thanks. Another question is, do you require documentation of 1114 translocation for venetoclax?
No, not at all. These are the vast majority of these patients are just MYD88 mutated. The only time you'll see 1114 is somebody who has IgM myeloma. On the differential, keep in mind that if you see somebody who's MYD88 wild type and has very, very high IgM level, I'm talking 6,000 to 8,000 or higher, in the back of your head, worry about IgM myeloma. They usually are 1114 translocated and they're cyclin D1 overexpressors. But you should not, this is not myeloma. You don't have to worry about 1114. These patients do extremely well with venetoclax. And I do see one of the questions here is, do we see TLS risk similar to CLL? No. In fact, it's very rarely ever see TLS in Waldenstrom. We usually start off at 200 milligrams and then dose escalate. And we do the TLS labs, as part of the dose escalation. But in that trial, we went up to 800 milligrams and we only had one laboratory TLS that didn't really manifest into a clinical symptom. So it's not the same risk as CLL.
Thank you. Another question is ibrutinib with venetoclax superior to ibrutinib or venetoclax as single drugs?
Don't know. The trial's still ongoing. That will be, of course, the readout of that trial, I have to be honest, is going to be a little bit difficult because what exactly are we looking for with the combination? Are we looking for more CRs? I hope so, because we don't get CRs very often in Waldenstrom. Can we get down to MRD level disease? I hope so. Can we just give 2 years of therapy, as that trial says, and then stop and see the patients have long, progression-free survival? I hope so. Those are really the endpoints that we're looking for. Can we get, the CXCR4 mutated patients to respond quicker? I hope so. So those are going to be the readouts that I think will come. But, patients, this is one of those trials that I think it's going to be harder to read out because both drugs are so effective. We'll see what the combination does.
Thank you. Another question is, what is your preferred modality of treatment for Waldenstrom presenting as AL amyloidosis?
Yeah, so this is a great question. We don't tend to see much activity with BTK inhibitors. So if you have somebody presenting with Waldenstrom's associated AL amyloidosis, I wouldn't use a BTK inhibitor. I would prioritize a proteasome inhibitor. Most of our data is with bortezomib. Just keep in mind that if the patient is transplant eligible, auto transplant eligible, I would prioritize them for consolidative auto transplant.
Another question is, do you see acquired von Willebrand disease and bleeding in Waldenstrom?
Absolutely. Whoever asked that question, it's a great question. And interestingly, as we've published this paper, Dr. Castillo from our group, you see this particularly among CXCR4 mutated patients. We don't have really an underlying pathology as to why that may be the case, but folks that are CXCR4 mutated are at higher risk for acquired von Willebrand disease. And these patients respond beautifully to BTK inhibitors. You just want to get that IgM down. It may take a while. So keep in mind that really the goal here is to get the IgM down. You do see reversal of the acquired factor.
Thank you. And the last question is, sometimes if MYD88 is negative, there's difficulty in differentiating Waldenstrom from marginal zone lymphomas. Do you face this problem?
Yes, yeah. I don't know who doesn't, but we do face this problem. Then it becomes a greater task to try to sort out, some subtle differences. You want to look at, the clinical presentation. The higher the IgM level, it favors LPL Waldenstrom. You want to look at the bone marrow. Usually with Waldenstrom's, it's intratrabecular, whereas with marginal zone, it's paratrabecular, and they don't tend to show as much plasmacytic differentiation. And also some of the chromosomal abnormalities, you can look at for subtle differences to help distinguish the two. MYD88 has given us a tool that, allows for that separation, but in and of itself, you still have to be friends with your pathologist and push them so you can, sometimes sort out these more rare cases.
Thank you so much, Dr. Steve. That's all we could accommodate. And grateful to you for having accepted this invitation, being with us, sparing your time on such valuable piece of information and update. Thank you so much.
Thank you, Dr. Agarwal. Always a pleasure. And thank you for the great questions. It really shows the great insight, that your audiences always tend to have. I wish you all a wonderful day, and thanks for letting me be part of your day today.
Thank you, sir. Bye-bye.
Bye-bye.
My pleasure to introduce the second speaker. She has already logged in. So once again, she is no novice to the people here. She was our guest a couple of years ago. She's also done some webinars for us. Dr. Lauren J. Nestor. She's Associate Professor, Section Chief Indolent Lymphomas, Section Chief New Drug Developments, Department Lymphoma Myeloma. And she's going to speak to us on follicular lymphomas today. Over to you.
Thank you. I sure appreciate the opportunity to be with you today. And it's kind of intimidating to follow Dr. Trion because he's such a good speaker, but I will do my best to cover today how we might consider optimizing treatment in follicular lymphoma. What is follicular lymphoma? I generally start with this, particularly with our patients, because I think the term non-Hodgkin lymphoma can be unfortunate. It's overutilized in the US. And so many patients will sit in our waiting rooms and discuss amongst each other and then be puzzled as to why they might not be offered treatment where other patients who also have non-Hodgkin lymphoma are undergoing intensive chemoimmunotherapy. And so I generally try to educate our patients that there are so many different subtypes of lymphoma, and it's really critical that they understand which subtype, because our expectations, our approach to this, whether or not this is something that could be fatal within a few years or something that may not even impact their life, is critical to understand. In the US, follicular lymphoma is actually becoming slightly less common. So outlined here, you can see it's about 12% of the new lymphoma cases per year. So it's about 14,000 cases diagnosed. So I am constantly reminded that it's a very rare subtype. Median age at diagnosis is about 63. So though we have a spectrum, I've had patients in their early to late 20s, though that's incredibly rare. I've also had patients diagnosed for the first time in their 80s. Most patients will be asymptomatic at presentation, though we often ask about B symptoms if they're present. I'm somewhat concerned about a concomitant aggressive histology. So about 10% of the time, patients presenting with follicular lymphoma will also have a concomitant diffuse large B-cell lymphoma. And the flip side of that, about 2 to 3% chance of transforming into diffuse large B-cell lymphoma per year over the course of their disease. Now, generally, I think that kind of plateaus around 20 to 30%. Given our outcomes of patients are continuing to improve, I've not seen any data suggesting that the rates of transformed disease are actually higher than 30% over their lifetime. Grading is still controversial in the US. We do render a grade. It's based off of the number of centroblasts seen per high power field. The reason why it's controversial is we don't think there's any distinction between grade 1 or 2. So oftentimes we're now reporting it as such. The threes are broken down between 3A and 3B, and it takes a skilled hematopathologist to really distinguish a 3B sometimes from diffuse large B-cell lymphoma. So because many patients in the US are first diagnosed in community settings where a pathologist may be looking at multiple tumor types, I would say it's pretty uncommon for 3B to be described in a community setting. Now, oftentimes these patients may be referred into an academic center such as ours, and we may tease out some of those rare 3B histologies. The question is whether or not 3A should be managed differently, because in my opinion, 1-2 is really no different. 3B should probably be approached like large cell lymphoma. I generally am approaching the 3A similar to the grade 1-2, unless there's some clinical concern that, again, there's underlying large cell lymphoma that I've just not been able to prove on biopsy. We are lacking in our risk stratifying tools, not because we don't have a number of models. We have plenty. This isn't the most comprehensive list. There's also a PRIMA International Prognostic Index that is an algorithm approach that takes into account beta-2 microglobulin in bone marrow biopsy. Because bone marrow biopsies are becoming somewhat less frequent given the increased use of PET-CT, I don't list that one on this slide, but this just highlights we have a number of clinical tools that help us risk stratify patients, either Flippy 2, there's an M7 Flippy that takes into account molecular features. And now that we're doing more and more sequencing of newly diagnosed patients, you might have this information available to you, at least in academic centers or among patients treated on protocols. The challenge with these tools is they don't help us define those really high-risk patients. They also don't inform treatment selection, so they're not predictive in any form. They're clearly just prognostic. Where they might be helpful is planning for patients, given it doesn't inform the risk for a given patient. Most of our patients want us to look into our crystal ball and tell them what's going to happen in the next 5 to 10 years. And so having this score can sometimes inform that discussion. The good news for patients is that our outcomes are improving year after year. We still see the best outcomes in first line or earlier lines of treatment. As we start to get to that third line or later space, you can see here outlined by these green curves, the progression-free survival starts to get short. Despite that, the overall survival is still pretty good. And even as we get in that 6+ line of treatment, again, patients are still facing quite favorable outcomes. So can we kind of dissect this a little bit and try and understand what's happening here? Chemoimmunotherapy probably still has a stronghold in frontline, and it actually works quite well for follicular lymphoma, as much as we're trying to move away from chemotherapy, just given the sort of negative connotations associated with toxicity and chemotherapy. It's hard to dispel the fact that it actually does result in quite meaningful remission durations. When we move into these later lines, despite the progression-free survival being about 12 months, just about any therapy you look at outside of maybe CAR T-cell therapy, because we have more and more treatments available for patients, those 12 months start to add up. And that's why we're still looking at pretty good overall survival, despite patients failing multiple lines of treatment. I do think that there is a role for observation even in 2021. And the reason I say that is because we have not found anything yet that will result in a one-time treatment for all patients. Now, some of our frontline studies will have a tail to those curves, and I'll show you some of that data, suggesting that maybe 20% of patients never relapse following frontline chemoimmunotherapy. But because we have no idea how to identify who those patients are, and because our trials don't follow patients out for longer than 10 years, oftentimes, we're all hesitant to use that word cure. For the majority of patients, they will likely face multiple relapses. And because this is a disease that the current life expectancy is projected to be at least 20 plus years, we have to consider each line of treatment, each indication for treatment, and the implications not only from an efficacy standpoint, but also a toxicity standpoint and how that may impact quality of life. So again, this is more like a marathon than a sprint. If I can delay treatment and it doesn't harm patients, then there's a good chance that I'm not going to shorten their life expectancy as a result of treatment complications. I generally follow the Guelph criteria. This is what we use for most of our frontline studies to enroll patients for therapy. Their objective findings, maybe with the one exception of B symptoms. In the US, almost every patient has fatigue. And so how you distinguish fatigue that's really impacting quality of life and could be improved upon by therapy is sometimes challenging. Whereas to me, it's easier to look at size and location of lymph nodes, labs, whether or not there's fluid accumulating in the thorax or the abdomen. These to me are very consistent ways to identify who warrants treatment. That being said, the question about whether or not it's still appropriate to observe patients in the modern era where we have therapy like rituximab, which has resulted in an improvement in overall survival, was potentially asked and answered by the Ardeshna study. Now, there were 3 arms to this trial, and one of the limitations of this study is that one of the arms was 4 weekly doses of rituximab. And because around the same time, we saw the results from the SAC study looking at 4 weekly doses of rituximab followed by 2 years of maintenance rituximab, looked like those were some of the most favorable outcomes we'd seen. The 4 weekly doses arm enrolled very poorly. The other rituximab containing arm mirrored the SAC trial, which was 4 weekly doses followed by 1 dose every 2 months for 2 years. As a result, they closed the arm with the 4 weekly doses. So really what we're looking at here is 2 years of rituximab therapy versus an observation approach. No difference in overall survival was observed, no difference in time to transformation. And so in countries where resources may be somewhat limited, it is easy to look at this data and say we have not altered the natural history of the disease by intervening early, even with a therapy such as rituximab. It's not surprising to me that you would have a longer time to next treatment or longer progression-free interval having had an intervention versus not. And that's another thing that we debate commonly in follicular lymphoma. What's the most meaningful outcome? And how does that inform whether or not a study is successful? Probably one of the most practice-changing studies was the STEEL trial, which looked at bendamustine in combination with rituximab versus R-CHOP. So this is not new information. I think I'll point out some of the important features. There was no maintenance utilized in this study. Patients who got bendamustine, a non-anthracycline approach, had a significant improvement in progression-free survival and time to next treatment. But to date, there's still no overall survival advantage, which leads some to still question what's the preferred frontline chemotherapy backbone. The PRIMA study, we now have longer follow-up. So PRIMA looked at 2 years of rituximab maintenance following frontline rituximab chemotherapy combinations. One limitation of the PRIMA study is it predated the introduction of bendamustine into follicular lymphoma. So about 74% of patients on this study had R-CHOP. The remaining had R-CBP or an R-fludarabine containing regimen. So 2 years of maintenance rituximab did result in a significant improvement in progression-free survival with a median of 10.5 years versus those who observed had a median progression-free survival of only 4 years. So that's a dramatic difference. So then why are we not seeing an overall survival difference? Again, this just highlights, even with now 10 years of follow-up on the PRIMA study, those patients who were initially observed, when they progressed and got their second line treatment, were able to catch right up to those patients who had a long first remission, just sort of highlighting that this is a disease where we anticipate that patients will have multiple relapses, multiple treatment over time. The gallium study set out to test whether or not obinutuzumab was a superior antibody to rituximab. On paper, it should be, meaning it's a type 2 antibody that's glycoengineered for enhanced ADCC. It's also humanized. In the relapse setting, when it was compared head-to-head with rituximab in a rituximab-sensitive population, the Gauss study actually didn't perform very well. It was no different, just slightly more toxic. But in the frontline setting, when combined with chemotherapy, again, in high tumor burden patients in the gallium study, it was a positive study. Now, a couple things to point about the gallium trial. In the first cycle, obinutuzumab is dosed on day 1, 8, and 15. So it's a little bit more dose intensity if patients were enrolled on that arm versus the rituximab-containing arm. Also, all patients who had a partial response or better went on to 2 years of maintenance. It's the first real prospective study where we see maintenance following bendamustine, which again, that was not done in the STEEL study. And each center decided at the onset which chemotherapy backbone they would be prescribing. So there's no personalization. It did introduce some unintended variables that were unmeasured, such as our perception that bendamustine is much better tolerated than CHOP. So patients enrolled in centers using bendamustine as the backbone actually had differences in comparison to those where CHOP was the backbone. Nonetheless, obinutuzumab, when combined with chemotherapy followed by 2 years of maintenance, did result in a superior progression-free survival. The study met its primary endpoint with about 3.5 years of follow-up. It's a very short time interval. Now, again, you could look at this curve and say, oh, it's kind of a modest difference in progression-free survival. But again, it's only 3.5 years. It's projected that over time, that's going to result in a more meaningful separation in time difference. It's just early. Now, there is no overall survival seen or difference seen thus far, which is not uncommon. I just showed you 10 years of follow-up on the PRIMA where that's still true. So it's hard to know if this PFS difference is going to inform practice patterns, given we've been debating that now for years. Probably one of the most impactful things about the gallium study was the toxicity. Now, if you look at the numerical rates of toxicity between the two antibodies, it's really not that strikingly different. I'll point out some key differences. In terms of the grade 3 or higher adverse events, you see more neutropenia with obinutuzumab than with rituximab. You do see more grade 3 or higher infusion reaction with obinutuzumab than rituximab. Most of that was confined to the first cycle. You see higher rates of cardiac events, thrombocytopenia. When we looked at this more closely, some of that, again, was partially due to the bendamustine, which led to sort of unintended selection biases. Some of these patients were frailer and more likely to have complications as a result of the perception that bendamustine is very well tolerated. Also, some of the infections occurred during the maintenance phase. Bendamustine clearly has an impact on T cell function. Now you're adding it to a drug such as obinutuzumab, where you can have more neutropenia. And so there was nearly a 5% rate of death on the bendamustine containing arm. And many of that actually happened during the maintenance, again, likely when patients aren't monitored as closely, which I do think raises questions. Should we be doing maintenance for all patients with bendamustine? And particularly in the COVID era, I have been avoiding that if possible. The relevant study set out to demonstrate that a non-chemotherapy arm was superior to rituximab in combination with chemo in frontline high tumor burden follicular patients. Now, the problem with the relevant study is they based this off of 2 single-arm phase 2 trials where lenalidomide rituximab performed quite well, but then extended the duration of treatment. Now, part of it was to try and match the control arm, which was 6 cycles of rituximab plus chemotherapy, followed by 2 years of maintenance rituximab. In the experimental arm, the lenalidomide rituximab was dosed with 20 milligrams on day 1 through 21 of a 28-day cycle with the lenalidomide. Rituximab had sort of a dose intensity during cycle 1. And then once they hit cycle 6, if they were in a complete response, they went into a maintenance phase with 10 milligrams of lenalidomide. If they were not in a complete response, they continued the 20 up until cycle 9, where they had another response assessment. So in general, it was about 18 months of the combination of R squared and then additional time period of rituximab monotherapy, again, to try and mirror what was done in the control arm. I think there are questions about whether or not a non-chemotherapy option has activity in certain groups of patients, including those with bulky disease, those with high-risk features such as elevated LDH, elevated beta-2 microglobulin, high-risk FLIPI. So I pull out some of the features of the baseline characteristics of the relevant study, and you had pretty healthy representation of those patients on this study and quite well balanced between the two arms. It did not meet its primary endpoint. So lenalidomide rituximab is not superior to rituximab in combination with chemotherapy in frontline follicular lymphoma. Now, I have heard many interpretations of this study, including those that say, well, this actually performed much better than we anticipated. Again, it's a non-chemotherapy arm, and we know that chemoimmunotherapy does quite well in frontline follicular lymphoma. And you can look at this progression-free survival curve and say, whoa, this does exactly as well. Now, again, because it didn't meet its primary endpoint, I don't conclude that it is just as good and can be considered just like you would consider our chemotherapy in frontline follicular lymphoma, but I acknowledge that it does perform quite well. If you look at subgroups, though, there's some interesting things to pay attention to. Looked like there was sort of a trend towards improvement if patients got our chemo, and particularly if they were treated in North America. Most of these patients actually had a bendamustine-based approach if they were treated in North America. So maybe R squared is not quite as good as bendamustine rituximab. Again, I don't know that you can conclude that, but that's an interesting observation. Interesting, too, that the low-risk FLIPI tended to favor more if they got chemoimmunotherapy, whereas the high-risk FLIPI, which we worry the most about, again, suggests they didn't do so poorly with R squared. This may just be the fact that the FLIPI score was derived in an era of chemotherapy and may not predict for outcomes for patients who get a non-chemo option. The toxicity is clearly different. Again, you could conclude that it's a lot easier in a non-chemotherapy option. Though I caution against that, because if you look at this curve, the rates of adverse events that are treatment emergent look to be more similar than different. A couple notable exceptions. Febrile neutropenia was higher in the R chemo arm, as was rates of grade 3 or higher neutropenia. Many of those patients actually got prophylactic growth factors, though you still see rates of grade 3 or higher neutropenia on the R squared arm. Most of that is reactive, meaning with dose reduction, dose interruptions, and then growth factor utilization. There was much less growth factors used on this arm. Higher rates of rash, though, this does appear to be rate limiting, meaning it usually occurs during the first cycle. It usually goes away with drug hold and usually does not recur with retreatment. In terms of second cancers, which I think is really important to explore, there was really no statistically significant difference and actually slightly higher numerical values if patients got the R chemo containing arm. So to summarize my approach to frontline untreated follicular lymphoma, I generally think that chemoimmunotherapy is worth considering because the outcomes are quite favorable. Generally, you could even consider 6 cycles of bendamustine rituximab, omit the maintenance, and likely are to achieve very good outcomes. The one situation where I might consider obinutuzumab over bendamustine rituximab, when I mean that, I mean obinutuzumab in combination with chemotherapy, or for young patients. Again, one of the subgroups of the Gallium study suggests that young patients did particularly well with the obinutuzumab containing arm, likely because they probably tolerated the toxicity more favorably. Maintenance, I consider in every patient just based off of the PRIMA study, but I will acknowledge in the era of COVID, I've been doing no maintenance. For patients who get frontline bendamustine, I generally do not pursue maintenance. for patients where chemotherapy is just not an option for various reasons. For any patient that I might consider rituximab monotherapy for that reason, those are the patients that I will administer lenalidomide rituximab because I'll show you some data in the relapse setting. My opinion is that R squared is much better than rituximab alone, and that would be the patient that I might apply the relevance data to, though I don't generally pursue the full 18 cycles of the combination. How do we risk stratify patients following frontline? Well, this is somewhat disappointing, but appears to be the most effective strategy thus far. It's really based off of response to their prior treatment. So there are two ways that we can identify high-risk patients. One is just looking at the end of induction PET. So Judith Trotman has looked at this across a number of prospective studies. The most recent study she's looked at this in is in the gallium study. And for patients who have a PET negative CR at the end of induction, so this is following 6 cycles, they have far superior progression-free survival and overall survival. So that suggests that those patients who fail to achieve a PET CR are a higher risk group. Now, we don't know if we can overcome that with things like maintenance therapy. Should we consider that a failure like we do in large cell lymphoma and move on to second-line therapy? These are unanswered questions, but at least it helps us risk stratify patients. The other tool to identify high-risk patients is monitoring how long it takes for that first relapse to occur. And so patients who progress within 24 months, we term them POD24 patients. Their median survival is far shorter than the other group. And the patients who don't have a progression event within the first 2 years actually have a life expectancy that should match an age match cohort, meaning they should live just as long as their friends who are their same age and sex, suggesting that we might be more mindful of toxicity and potentially less aggressive in these patients. There are a number of novel treatments in the relapse refractory setting. As we move into that portion of this discussion, I highlight just the FDA approved agents, not those that are still in investigation, but just those that have been approved since 2014. You see it's a quite lengthy list. So I'll walk you through some of the data in my approach in terms of how I might navigate this ever expanding and complicated treatment landscape. But back in 2014, we had the first PI3 kinase inhibitor approved. In 2021, we had the fourth PI3 kinase improved. In 2019, R squared became available for patients with relapsed follicular lymphoma. We now have CAR T-cell therapy in the US approved for patients in that third line or later state. And we have tazemetostat, an EZH2 inhibitor now available. The AUGMENT study led to FDA approval of R squared or lenalidomide rituximab. There are a number of different strategies in terms of dosing across studies in follicular lymphoma, but the AUGMENT study did pursue 12 cycles. It's not a maintenance therapy, but it's potentially a prolonged treatment. So patients get weekly dosing of rituximab for the first 4 weeks during cycle 1, and then they get dosed on days 1 of cycles 2 through 5. So it's essentially 6 cycles of rituximab, and then it stops. Lenalidomide is dosed at 20 milligrams on days 1 through 21 of a 28-day cycle, though it's important to remember to dose reduce patients if they have a creatinine clearance between 30 and 59. And then it was a placebo-controlled arm with the same dosing strategy with rituximab in the control arm. You can see that the study met its primary endpoint and potentially quite impactful if you look at the separation of this progression-free survival curve, early separation, maintained distance between those two curves. The median PFS among the patients who got lenalidomide rituximab was about 39 months versus 14 months for those who got rituximab monotherapy. Now, this was studied in a rituximab-sensitive population, given rituximab monotherapy was the control arm, and you could conclude that this likely selected out for very good risk, less heavily pretreated patients, and I think that is a fair assessment. That being said, about a third of patients get rituximab or CD20 alone in that second-line space in the US, and so I do think that this addresses a question: who should be considered for rituximab alone moving forward, given we now have R squared as a very good, more effective strategy. When we look at the toxicity rates, particularly second cancers, again, numerically slightly higher on the rituximab alone arm. Similarly, we don't see significantly higher rates of thromboses, and the histologic transformation rate, again, slightly lower with R squared than rituximab monotherapy. So I think that R squared should be considered for every patient in that second line setting, based off of the fact it's much more effective than rituximab alone. We don't see any signal in terms of toxicity that would be worrisome. When we look at the subgroup analysis, about the only group that did not tend to benefit from R squared was the marginal zone lymphoma patients. Now, again, you could conclude because these patients do quite favorably with rituximab alone. Despite this, it was a small population. That being said, it is FDA approved for marginal zone lymphoma in the US, but that is potentially one group where I do reserve R squared until later lines of treatment, just based off of my opinion that I don't think it is as effective as other options for marginal zone lymphoma patients. Among the patients with follicular lymphoma enrolled on the AUGMENT study, we do see an overall survival advantage. That was a significant difference. You can see a pretty profound hazard ratio here. I do think this is notable given, again, many of these patients would likely experience multiple relapses, multiple treatment over time, and it would be anticipated that the patients getting rituximab monotherapy would be considered for R squared at a later date. So this suggests that that impact seen early in the disease course is maintained over time. And again, another consideration for R squared in second line. I mentioned there are 4 PI3 kinase inhibitors approved. How do I choose among the available options, and are there distinguishing features? Well, I do think that the toxicity profile is probably distinguishable, and it's likely informed based off of the selectivity against the isoform of the PI3 kinase inhibitor for which these agents have selectivity. All of them inhibit the delta isoform, but some of them inhibit additional isoforms. So for instance, copanlisib is actually a pan PI3 kinase inhibitor, though most of its selectivity is against alpha and delta. Duvelisib is a gamma delta inhibitor. Again, most of its activity is spread between the two. And then umbralisib has a CK1 epsilon activity, which it's unclear what the relevance of that is, but suggests that that is, a distinguishing feature. The overall response rate appears to be maybe more similar than different, but again, very different study populations. The median progression-free survival, again, different, but I don't think that we should compare that so much across these studies. But I do think that the toxicity profile is probably one of the distinguishing features. So copanlisib is an IV formulation with intermittent dosing, which may lead to less frequent GI toxicity. It might be an option for patients who can't tolerate oral therapy or who potentially have insurance issues in the US for oral therapy. The flip side to that is for patients who have uncontrolled hypertension or diabetes, that may not be the best option. Now, based off of the phase 1 data, the elevation in blood pressure and blood glucose peaks at about 5 hours after the initiation of the infusion and returns to baseline within 24 hours. So it's imperative not to react to those values, and particularly not to treat them, because you may lead to overcorrection. The best strategy, though, is actually to only pursue this therapy in patients who have controlled blood pressure with a systolic of 160 or better, controlled diabetes with a fasting blood glucose of 180 or better, just to avoid those situations where you have anxiety among the patient, anxiety among the infusion nurse, and trying to avoid our anxiety of not overreacting to it. The oral agents tend to have more GI toxicity in the form of liver enzyme elevation, diarrhea. All of them have the potential for some immune-mediated toxicity, such as colitis, pneumonitis, rash that may be immune-mediated in etiology. And though those are infrequent occurrences, those are probably the toxicities that need to be monitored for and managed. Generally, we hold drug. If the toxicity is severe or progresses, then we generally will initiate steroids as well. Some of the most recent data is the Chronos 3 study. So this looked at copanlisib in combination with rituximab versus rituximab monotherapy. So this is their confirmatory phase 3 study. Copanlisib was FDA approved based off of a single arm phase 2 trial with single agent copanlisib. So now this is copanlisib rituximab versus rituximab monotherapy. Very similar study schema as we saw with the augment study, with the difference that it's not 12 cycles and stop. This is continuous therapy with the copanlisib. You can see there's a nice separation of the curves. Median PFS was about 20 months versus about 14 months with rituximab placebo. Kind of striking to me is that the control arm, rituximab monotherapy, performed very similar to what we saw with rituximab monotherapy in the augment study, suggesting, again, this is a pretty similar patient population. Umbralisib is the most recent FDA-approved PI3 kinase inhibitor. It's an oral therapy. Kind of interesting is the FDA approved it in 4th line or later, so that's one distinguishing feature with umbralisib. It probably has one of the best toxicity profiles, given lower rates of discontinuation as a result of toxicity. You can see outlined here, the Unity study included multiple indolent lymphoma histologies, and the blue curve is follicular. Maybe a hint that it performs better in marginal zone lymphoma and small lymphocytic lymphoma than in follicular lymphoma. Maybe not surprising, since targeting the B-cell receptor signaling pathway seems to be more effective in CLL marginal zone lymphoma than what we've seen to date with follicular lymphoma. Tazemetastat is an oral EZH2 inhibitor that's now approved for relapsed follicular lymphoma. EZH2 mutations occur in about 20 to maybe as high as 30% of follicular lymphoma tumors. It appears to be a stable mutation, meaning those rates are probably the same, whether it's newly diagnosed patients or those in the refractory state. It likely has multiple roles. It's probably not the driver of this disease, but one of the functions of EZH2 when it's mutated is it kind of stops that B-cell maturation. So as opposed to these immature B-cells making it all the way to the plasma cell state, their maturation arrest occurs in this germinal center where they're exposed to multiple rounds of somatic hypermutation, and then they accumulate more mutations with the translocation 1418. They have overproduction of BCL2, so then they avoid sort of natural apoptosis. So that is one potential role. The other potential role is probably also in the immune microenvironment. So EZH2 likely, as do other epigenetic modifications, have an impact on immune surveillance and essentially providing this sort of pro-tumor microenvironment for patients. We know that for tazemetastat, the interesting finding is that the single-arm phase 2 study enrolled about half the patients had EZH2 mutation and half the patients had EZH2 wild type. So they tried to enrich for the mutant population, acknowledging that the majority of patients are going to be wild type. The response rate was much higher among the EZH2 mutant patients, so about 69% overall response rate, whereas it was about 30% among the wild type population. But what was intriguing is the duration of response was essentially identical. Now, again, it's a smaller portion of patients responding in the EZH2 wild type group. However, if you look at the median PFS across the study, again, you saw a median PFS of about 11 months among the wild type and about nearly 14 months in the mutant population. So only a difference of about 2 months, despite this quite striking difference in response rate. So this now raises questions. Why do we see almost similar outcomes among patients who are EZH2 wild type? Though we don't fully understand that, again, it's likely the impact of the microenvironment in addition to the impact on the tumor itself. The toxicity profile of tazemetastat is probably what sets it apart. So you can see here, no grade 4 toxicities, very few grade 3 toxicities. The vast majority of the adverse events were actually grade 1. Only 5% of patients discontinued treatment as a result of toxicity, and 9% had dose reductions, which again is quite striking if you think about the rates across other studies in this setting. So as a result of this toxicity profile, there's an interesting label with tazemetostat. So it's currently FDA approved for patients who've had 2 prior lines of therapy who have the EZH2 mutation. So to qualify for the single-arm phase 2 study, you had to have failed 2 prior lines of therapy. However, it's also approved for patients with relapsed follicular lymphoma in the relapse setting, independent of how many lines of therapy and independent of the mutation status, suggesting that for patients who are wild type, you can have access to this drug if you don't have an acceptable standard of care, suggesting if the toxicity profile is more favorable than the other options available to the patient, and they're potentially frail or have comorbidities where the other options are just not acceptable. That now raises the question, should we be testing for EZH2 on every patient or not? And so there is a companion diagnostic that is available where you can order just EZH2 mutation. In large centers like ours, we're doing next-gen sequencing on nearly every new follicular lymphoma patient that comes through. And so we have it as part of our larger panel, but I think you could also make the argument that maybe you don't have to have it to decide if you want to use tazemetostat or not. I mentioned that we have CAR T-cell therapy available now for patients with relapsed follicular lymphoma, and it's based off of this single-arm phase 2 study called ZUMA-5. So to remind everyone, this is the same axi-cell that's approved for large cell lymphoma. It's a CD19 autologous CAR with a CD28 co-stimulatory molecule. So this study enrolled follicular and marginal zone lymphoma patients. Now, they tried to enrich for a high-risk population, given the perceptions of the toxicity of CAR T-cell therapy and the logistical challenges around it. So these were patients who had failed at least 2 prior lines of therapy that must have included chemoimmunotherapy, and there were time windows in terms of when those progression events had occurred. Similar schema as we've seen with the ZUMA-1 study, again, just a different population. So to remind everyone, these are patients, they undergo leukapheresis with axi-cell, fresh PBMCs are collected, a retrovirus is used to modify these cells so they then express an extracellular CD19 target, and you got the CD28 co-stimulatory. Manufacturing takes about 17 days. Once cells return to the treating center, patients undergo lymphocyte depletion with fludarabine and cyclophosphamide, and then 2 million cells are infused per kg. The response rate in the study was very high, and particularly among the follicular lymphoma patients, you can see a complete response rate of 80%, which is higher than anything we've seen thus far. Now, again, response rates being high in CAR T-cell therapy is not anything new. What was also potentially striking is that we see a median PFS that hasn't been reached yet with 17 months of follow-up. I started this discussion saying that most therapies in that 3rd line or later space is going to result in a median PFS of around a year. We don't know what the median is yet. So this appears to be one of the most effective therapies we've seen thus far. Similarly, overall survival is quite high. Now, you could also look at this and say, well, the marginal zone patients don't do very well. And as a result, that arm of the study is still enrolling, and the FDA did not approve axi-cell for marginal zone lymphoma, though it is approved for follicular. I think the questions we're all facing is, should we consider CAR T for every relapsed follicular lymphoma patient, given they have so many options and the toxicity is not minimal? So about 6% of patients with follicular lymphoma have grade 3 or higher CRS. So that generally means pressors, sometimes high flow oxygen, or even mechanical ventilation. 45% of patients did require tocilizumab. There was no grade 4 events, but there was 1 grade 5 event, meaning a patient died as a result of toxicity. Neurotoxicity, about 15% of patients will have grade 3 or higher neurotoxicity. So these are generally patients that also require ICU monitoring. And you can see rates of corticosteroids about 31%. So again, something worth considering. So it's balancing the sort of healthcare resource utilization, the toxicity, with the very favorable efficacy. There is a potentially better tolerated CAR T that's anticipated to be FDA approved for follicular lymphoma. Tisa-cel, which is, again, another autologous CD19 CAR with a 4-1BB construct. In large cell lymphoma, we've seen very favorable rates of cytokine release syndrome and neurotoxicity. This is a single-arm phase 2 study in follicular lymphoma. Again, quite meaningful CR rates. Median duration response has not been reached with about a year of follow-up. Very favorable toxicity, no grade 3 or higher cytokine release syndrome. one patient with grade 3 or higher neurologic events. So maybe a safer CAR T might get more uptake in follicular lymphoma, but probably the biggest challenger will be the bispecific antibodies. So this doesn't require leukapheresis, doesn't require manufacturing, it doesn't require treatment at a certified center. There are a number of bispecifics that are under exploration. Most of these will have a head that targets CD20 and then a T-cell engager CD3. Many of them are IgG antibodies, which then allows for less frequent dosing in comparison to blinatumomab. Nearly all of these agents are dosed either weekly or every 3 weeks. You can see here early phases of this, small sample size, but the response rates appear to be very promising. Nearly all of them will have cytokine release syndrome, though usually it's confined to the first cycle. Rarely is it greater than grade 2 in severity. And we've not seen much neurotoxicity to date, which is also quite striking. Mosunetuzumab is probably the furthest along in follicular lymphoma with a sample size over 60. You'll see potentially an update this year at ASH, but at the summer meetings, we saw some updates. So this has a ramp up during cycle 1. So a very low dose on day 1, a little bit higher dose on day 8, and then full dose by day 15. And then again, every 3 weeks. This is dosed until cycle 8 among those patients who've had a complete response. For those who have at least stable disease, it continues up to cycle 17. So it's not a one-time infusion like CAR T, but it has a fixed duration of treatment, which I think is intriguing. And we see efficacy across a number of subgroups, including a small number, but those that have had prior CAR T, those that are POD24, those that are double refractory, meaning refractory to chemo and CD20, and those that have also failed a PI3 kinase inhibitor. As I mentioned, cytokine release syndrome appears to be one of the most common toxicities. It's the second bar here. Nearly all are grade 1 with a few grade 2s, no grade 3 or higher observed thus far. The top bar up here is hypophosphatemia, which potentially is a biomarker of T-cell engagement, followed by fatigue. And then you start to see infrequent toxicities outlined here. So in general, it's pretty well tolerated. I think the questions that might impact uptake is whether or not patients have to be hospitalized or near a center that can administer tocilizumab during cycle 1 to mitigate the CRS. There are strategies such as step-up dosing, more aggressive corticosteroids or steroid pre-meds, potentially even ways to bind up B-cell targets such as pre-treatment with obinutuzumab or subcutaneous administration. All of these are being explored right now to try and improve the toxicity, particularly during cycle 1. So I will end by my approach currently to follicular lymphoma. So most patients, I will say, will have chemoimmunotherapy in frontline. Now, some may have R-squared. Again, those are patients where I might consider rituximab monotherapy. At progression, particularly if it's a POD24 patient, I will biopsy to ensure, 1, I know it's still follicular lymphoma, and 2, it's not transformed disease. If patients have had prior bendamustine or a non-anthracycline approach, if I don't have any concern for histologic transformation, I will go to R-squared. If patients have had prior bendamustine, or have had prior anthracycline, then again, I will consider either R-squared, or you do have the bendamustine in combination with obinutuzumab based off of the Catalan study. What would sway me one way or the other? There are some patients that just, again, either can't handle oral therapies, or they want a 6-cycle completion as opposed to 12 cycles. So again, it's sort of personalized according to patient preference, but R-squared is generally my preferred second line approach. If I have an early relapse post second line, these are the patients that I do take to CAR T-cell therapy. If I've not used maintenance in frontline, I might consider maintenance, particularly following bendamustine, though again, not as common in the COVID era. And then for third line, if I have an EZH2 mutant patient, I might consider tazemetostat first prior to a PI3 kinase inhibitor. If I have an EZH2 wild type, I'm generally doing a PI3 kinase inhibitor first, unless I haven't had R-squared yet, in which case I would use R-squared over both of those options. CAR T, again, I will reserve for those patients that are progressing relatively quickly through therapy, and I'm not pursuing auto or allogeneic stem cell transplants currently. Obviously, clinical trial is my preference, but for those that don't practice at Anderson, I try and list sort of my standard of care option. I think the question will be, where do bispecifics fit in all of this? I anticipate the bispecifics will probably be tried before CAR T in that third line space, but then start to move up into earlier lines, either as single agents or in combination. So I'll conclude by highlighting that outcomes for follicular lymphoma continue to improve, and that's likely the result of novel targeted agents that are being approved in the later lines of treatment and now moving into earlier lines of treatment. This ever-expanding treatment landscape creates challenges for clinicians to walk patients through all of the available options, and there is no one approved or best approach. I think each provider probably has a comfort level with the toxicity profile of a given agent. I walked you through sort of my preference and informed you based off of some of the data that might inform that choice. I think there is a paucity of randomized studies, which makes it really challenging for us to be committed to our convictions. I do think that creates an opportunity for real world data to potentially explore how some of these single arm studies compare to our standard of care options. And our overall survival is very favorable, despite our progression-free survival intervals getting shorter and shorter with subsequent lines of therapy. I think something like CAR T will quickly have uptake if we can demonstrate you can cure patients, because if we can demonstrate a one-time treatment can result in the last treatment, we'll be less cognizant of the toxicity. I just think it's way too early to conclude that. And so with that, I will stop sharing, and I'm happy to answer any questions.
Thank you so much, Dr. Loretta. That was a beautiful update on this particular disease. We have some of the Indian colleagues who will be asking you some questions. And there are some questions from the audience. Many of the questions from the audience are related to if there is a localized stage 1 or 2 disease, can it be cured with radiotherapy?
Yeah, I think that's a great question. I didn't spend any time talking about that. I do think that for limited stage disease, you can likely cure about 50% of patients. But for 50% of patients, they're going to relapse. It's sort of a flip of a coin, and I don't have a better way of defining who's likely to be cured. I generally will consider radiation if it's in a location that I'm not concerned about late toxicity, meaning either in the neck, under the arm, in the groin. If we're talking about abdominal disease, generally I'll just observe those patients.
Thank you. Faculty here, Dr. Jayachandran. Can everybody open their videos? We have
That was an excellent.
Go ahead, Dr. Jayachandran.
I was just in a 90-day issue, so I just switched off. Yeah, that was an excellent lecture, madam. Am I audible, sir?
Yes.
Yeah. So I have a couple of questions. The first question is, would you consider rituximab maintenance in a patient with composite lymphoma with follicular and large B-cell lymphoma? And my second question is, we do not have any fancy drugs, newer drugs in India. So what is the role of autologous stem cell transplantation? Would you consider, what is the group of patients would you consider? Would you recommend us to consider in a first relapse?
Really good question. So I didn't show this data, but for patients who are anthracycline naive, whether it's a composite lymphoma or transformed lymphoma, usually they have very favorable outcomes with R-CHOP, and usually as good as de novo large cell lymphoma. So if I have a composite lymphoma, I will give R-CHOP. If I have a patient that has transformed and has never had R-CHOP, I would recommend R-CHOP in that setting. I think your question about auto is a very good question. And so we've been debating this now for some time, and auto and allogeneic stem cell transplant has very low use in the US. So there's some data that we worked on where we summarized outcomes across 8 centers, and not all of these patients were treated just at these 8 centers, but at some point had come through our doors. So about 20% of patients in the US have had an auto transplant at some time. In my opinion, and this data has been validated by the Nebraska group, if you use it within the first 3 lines of therapy, you have quite good outcome. If you use it beyond 3 lines of therapy, you're probably just going to be putting the patient at risk for second cancers, and that rate is as high as 12% in terms of treatment-related MDS. And so I think if that's in your toolkit, use it, but use it early. The other data to inform that is a retrospective study of the CIBMTR looking at POD24 patients, and they also showed that it is very effective among those patients if you use it within 12 months of that POD24 event. So just about every situation that's been looked at, earlier use of auto better. I'm not consolidating patients with auto though now, particularly that we have CAR T, meaning if I have a transform patient, I don't give them R-CHOP and then follow with an auto, which I'd say we were doing about 10 years ago. We're no longer doing that.
Regarding my first question, so I did ask for the role of rituximab maintenance in.
Oh, I'm sorry. Yeah, rituximab maintenance.
Composite. Maintenance
Yes.
and composite.
Yeah, so maintenance in large cell lymphoma has never been demonstrated to be of any benefit, but the maintenance, particularly following our CHOP in the PRIMA study in follicular, looks really good. So we actually had a fellow look at this last year. It's published now. There's a slight benefit in those composite lymphomas if they get maintenance, but it's not as impactful as I would have liked to have seen. So again, in the COVID era, I'm not doing it. I think in an era where we're not dealing with the pandemic, then it's reasonable to consider, but it's not as impactful as it is in just follicular.
Thank
you. Dr. Aditi.
Good evening, ma'am. My question is, what is the chemotherapy of choice for pediatric or adolescent lymphomas, especially when they are higher grade and usually having favorable prognosis?
Yeah, that's a really good question, and recognize I don't treat any pediatric patients, but I also have been thinking about this recently. Bendamustine has been my preferred chemotherapy of choice. That being said, it definitely has an impact on T cells. It also probably increases the risk for second cancers, though not as much for your treatment-related MDS, but we see a lot of second cancers, so particularly skin cancers, solid tumors. And so I do actually think about it a little bit more in my younger patients. Again, younger to me is less than 40. It's not a pediatric patient population, but I do take pause a little bit with bendamustine in younger patients. And so generally, I think for those in that 20s to AYA population, we're generally managing them along with the pediatric group and following their cooperative group studies. But I do think that's one situation where I probably would avoid bendamustine.
Thank you.
Thank you. Dr. Ankur.
Good evening, ma'am, and it's a very nice presentation. My question is, how frequently you monitor these patients, and once they relapse, are there any criteria to start the treatment or just to wait and watch if they are asymptomatic, like the gel?
Yeah, great question. So we have been doing less surveillance imaging recently. Part of that is driven by insurance and not covering it, but I also think it's probably the right thing to do. So even at a center like Anderson, where I am not resource restricted, we're getting scans every 6 months for the first 2 years. And then beyond 2 years, we're going to once a year till they hit about year 5. And then year 5 moving forward, it's kind of, we're not getting a scan every year. We're seeing them once a year. And if there's an indication for a scan, either based off of labs, history, exam, then we'll get one. I think that's probably over time will be something we do even less frequently, but that's how we're monitoring them currently. At progression, I don't just start treatment. I generally will still follow the GELF, though it's not as well validated in the relapse setting, though you're starting to see more and more studies in the relapse setting report at least how many patients on their study had GELF criteria. It's rare for a trial in the relapse setting to require it, though. So that just demonstrates that we acknowledge it's still helpful in identifying who should be treated. We're not restricting treatment just to those criteria.
Thank you, Dr. Jatin.
Thank you, Dr. Loita, for the wonderful presentation. My question is, in the elderly, whether you are still using any subset of patient where you are still using single agent rituximab in frontline? And the second question is, if such patients progress later on, can rituximab len can be a good sequential second line therapy for them?
Yeah, it's a good question. So I've mentioned that if I'm going to consider rituximab alone, I might consider R squared just based off of the augment study in the relapse setting, suggesting it's much better than rituximab alone. So if I have a potentially fit elderly person that we're just trying to avoid chemotherapy for various reasons, then I do consider R squared. Am I only giving R squared? No, I actually have quite a few patients that I've given rituximab monotherapy. What I generally will do is give 4 weekly doses and hope that I get a really long remission. And if I don't get, so I will scan them about 13 weeks later. If I didn't get as good a remission as I want, then I'll generally add in the R squared at that point or the lenalidomide at that point. So I kind of will do sort of the litmus test to see, is rituximab alone going to do it? So if I can give 4 weekly doses and they hit a CR, and that I feel like I'm kind of done and I can just sit on that patient for a little while. I think that you have to be mindful of bendamustine in elderly patients. We tend to see, or my experience, a lot more cytopenias and a little bit more intolerance, even though we view that as pretty well tolerated. So I think you have to do a dose reduction, but I generally will do rituximab 4 weekly doses. If that didn't get what I want, then I'll add in the lenalidomide. I usually dose reduce len. I'll usually start at 10 milligrams in my older patients. That's much better tolerated. And then if they still have issues later down the line, I might give them low dose bendamustine, again, starting around 70 milligrams per meter squared. So that's generally sort of my sequence.
Thank you.
Dr. Roshni.
The first question is, in a frail, very elderly, like 85-year-old, but no comorbid, with bulky disease in the neck and some bulk in the mediastinum, would one prefer radiation versus rituximab, single agent? Chronic UTIs, so some renal impairment.
Yeah, I think if you can fit it into a one radiation field, it's reasonable. If you're having to do, 2 different sites, or if it's a huge field, I probably would avoid radiation and start with single agent rituximab and see how much benefit you get. We have a study where we're doing 4 gray of radiation. It actually works really well. So my really older patients, if it's within a radiation field, that's what I generally will do, is just 4 gray. And that actually does quite well.
The second question is that everywhere in India, we may not have access to PET CT. So in the frontline setting where one is not suspecting transformation, when should we do a PET CT, or can we get away without a PET CT?
Yeah, I would say you don't have to have a PET CT. So Judith Trotman has reported this now as well. The SUV max is actually not a strong correlate for transformed disease. I think a PET at baseline will definitely give you a better stage than just a CT, but it doesn't actually help you pick up your transformed disease. Our clinical skills are probably better actually than PET. Elevated calcium, elevated LDH, B symptoms, rapidly growing masses. That's what clues you into transformed disease more so than that SUV max. If you have a choice where you could get one PET, the end of induction PET, I think, would be very helpful, because that can give you a sense in terms of both PFS, but also overall survival. And so that's the one situation where if you have a choice, get it. If you don't have a choice, then a CT is reasonable at the end of induction. But again, what if you have, 60% reduction in tumor volume? You don't really know if that's a partial response or it would have been a PET CR. I tend to see that more in bulky disease. When you have a lymph node over 7 centimeters at the start, usually it doesn't just melt away, but the SUV disappears. I'm going to be less concerned about that patient, but that's probably where maintenance probably would fit in. If you don't have a PET, you just have a CT, they've had a marked improvement in tumor volume, but they're still in a PR. It's probably where I would throw the maintenance in.
Thank you, ma'am.
We'll take a couple of questions from the audience. If there's a young person and he has multiply relapsed after 3-4 lines of treatment, CAR-T is not available, can you go for allo transplant?
Absolutely. I think the whole rationale behind CAR-T and behind rituximab is that we know the immune system can be effective at eradicating follicular lymphoma. We've just struggled to get a given person's immune system to do all the heavy lifting. So yes, absolutely. Having a good donor so that they're not at risk for GVHD is probably the most critical component, and having them in a pretty decent, at least good partial response are probably the 2 areas where if I don't have either of those, then I might not do it.
Thank you. Is there any data on the use of polatuzumab with PR?
Yeah, so that's interesting. So the original study done by Lori Sin that was BR plus minus polatuzumab had 2 cohorts. It had a large cell lymphoma cohort and it had a follicular cohort. They have only published the large cell lymphoma cohort because that was the only arm that was positive. They've reported the follicular cohort. There was absolutely no difference in polatuzumab BR versus BR alone in follicular lymphoma. Now, again, you could argue because BR is actually effective in follicular, where in large cell it's not effective. And then therefore it was hard to see much benefit or impact of polatuzumab. But you could also argue that polatuzumab just doesn't work in follicular. So it's not gone, it's still being studied, but in different combinations, and it's not made it into a randomized study yet.
Thank you. Next question is, do you use tazemetostat in combination with chemotherapy?
Yeah, so those are all the studies that are underway right now. So the French group has looked at tazemetostat in combination with R-CHOP, looks to be very favorable in GCB large cell lymphoma, but also in follicular lymphoma. For us, that's not as impactful yet because we don't actually use much large R-CHOP unless we're dealing with transformed disease. We have a study right now where we're giving tazemetostat in combination with lenalidomide and rituximab, but the rationale that we could further augment the immune response. And so I'm eagerly or excited about that study. It's a little too early to know if it's going to be better than R-squared alone, but it is randomized. So that will give us an answer with other sort of non-chemo combinations too.
Thank you. Another question is about refractory follicular lymphoma. After your first line of therapy, do you immediately go to the next line of treatment?
So I generally would try and put that patient on a study where I've had a little bit of challenge clinically. So I've had a couple of patients that have either R-CHOP and then BR or vice versa, and we go from one right to the next one pretty quickly. I always biopsy those patients to make sure that they're not transformed. The challenge that I've seen with going from one cycle or one course of chemo right to the very next one is you tend to run into issues with cytopenias. So I have a couple of those patients right now that they're just clinically challenging for me because I feel like I'm constantly dealing with infusion or transfusions and risk of infection. So I always get a little bit nervous about those types of situations. But yes, obviously I generally do. If they're refractory, those are high-risk patients, and those are the ones I'm setting up to try and get to CAR T as soon as I can.
Thank you. Is there a place of NGS studies at diagnosis or during follow-up?
We do, so I know that we do it, though not 100%. I would say probably not as much as we want to do it. We realistically only get about 20% of cases where we have enough tissue where we can get NGS because it's not being done in community practices. It's only being done in academic centers. I know Memorial Sloan and Mayo do it in every follicular lymphoma patient as well. The challenge to date is it's not been helpful information. You can potentially calculate a M7 Flippy score. Having an EZH2 mutation might be informative for later lines, but that's only for about 10 to 30% of patients. And so as much as it's sort of a concept of luxury, it's actually not that informative. So I don't know that I would be doing it if I was not in a center where I had access to it.
Thank you. How do you handle patients of follicular lymphoma with CNS infiltration?
Yeah, fortunately, that's rare. It can happen. If it's there, I'm probably on the lookout for signs of large cell lymphoma. We generally approach it just like we do for large cell lymphoma. If it's a local extension, so we do have a couple of patients that will have sort of dural involvement. And if it's not truly penetrating into the CNS, then those we might consider for combined modality with chemo and radiation, so a short course of chemo and radiation therapy. If it's parenchymal disease or leptomeningeal disease, then we approach it just like you would a large cell lymphoma.
Thank you. And the last question is, do you monitor MRD in peripheral blood or bone marrow at the end of the treatment?
No, not in follicular lymphoma. So the problem is, if you look across all of the studies where you use PCR, the rates of MRD negativity are quite high. They've never really correlated very well with PFS. The cell-free DNA in follicular lymphoma is not quite as sensitive yet as it is in large cell lymphoma. So it's not a reliable tool. We're hoping that that may change over time as the technologies evolve. But as of right now, it's not helpful to know the MRD status in follicular lymphoma.
Thank you so much, Dr. Loretta. You have done a wonderful job. First of all, you accepted our invitation, gave us so much of knowledge, updated till today, and answered all the questions of our colleagues here. Thank you so much, and have a wonderful day ahead.
Thank you. I sure appreciate the invitation. Phenomenal questions. Have a good one. Bye.
Thank you. So that brings us to the introduction of the last speaker of this series of webinar, and that is Dr. Lauria H. Sen. Many of you, or most of you, must have learned your lymphoma by reading her publications. Prolific researcher. She has been in this field for 30 years and has done human service to patients affected by especially DLBCL, but also probably any type of lymphoma. And she is the chair, Lymphoma Tumor Group, BC Cancer Center for Lymphoid Cancer, clinical professor of medicine, Division of Medical Oncology, University of British Columbia, Vancouver. And she's going to speak to us on diffuse large B-cell lymphoma. Kalpesh, start.
Hi, I'm Laurie Sen from BC Cancer in Vancouver, Canada. And I'd like to thank the meeting organizers for inviting me to speak on an update on diffuse large B-cell lymphoma. I'll be covering some recent data along with some data that was presented at the ICML meeting. These are my disclosures. So at ICML, I actually participated in a debate as to what was the current frontline standard treatment for diffuse large B-cell lymphoma. Dr. Nowakowski, who is my worthy opponent, was trying to argue that we moved beyond R-CHOP, but the reality is that currently today, R-CHOP remains the standard for diffuse large B-cell lymphoma. We know that it's an effective regimen for a large percentage of patients, so about 70% can be cured with R-CHOP. However, unfortunately, about 30 to 40% of patients will fail R-CHOP, and for those patients, they often do so early, demonstrating chemotherapy resistance. So we need to find something better. The problem is right now we haven't quite identified that something better. We do know that diffuse large B-cell lymphoma is not one disease, that biologically it's been at least 20 years that we've recognized there are two distinct subtypes based on what we call cell of origin. So this was based on data looking at gene expression profiling. And what we can see is that there were two main groups of diffuse large B-cell lymphoma that had very different levels of gene expression and relied on very different oncogenes. So perhaps giving us the opportunity to target novel agents to these unique subtypes to make outcomes better. Well, we have seen a series of randomized controlled trials trying to introduce novel agents to make R-CHOP better. Some of these have actually explored targeting these novel agents in the subtype that we think they're most likely to be beneficial, primarily the non-GCB or ABC subtype. And despite all of these randomized controlled trials, we have yet to identify a successor to R-CHOP. So unfortunately, none of these trials were technically positive. The world of diffuse large B-cell lymphoma, however, is getting more complicated. So going beyond gene expression profiling, looking at the actual genetic mutations themselves, we now recognize that we can actually segregate diffuse large B-cell lymphoma into even smaller groups. So various groups have actually looked at genetic mutations in patients with DLBCL, and there have been different proposed algorithms. This is one that's come out of Dr. Lou Stout's lab, which I think everybody is now in agreement with is likely reflective of true biology in diffuse large B-cell lymphoma. But you can see that when we look at the ABC and GCB subgroups, and we put on an extra layer of gene mutations, losses, and gains, you can see that even within the GCB and ABC subgroups, we now recognize that there are unique subtypes within those. So sort of the thought process that all ABC subtype patients had a poorer prognosis and all GCB subtype patients had a better prognosis, we now recognize that within the ABC fraction and the GCB fraction, there are actually good risk patients and poor risk patients. So I think we're going to need to use this information as we move forward with the next series of trials. One of the I'd say most talked about abstracts that was presented at ICML was this interesting oral presentation that looked at using this newfound knowledge that we have in genetic subtyping and trying to improve upon it by providing targeted agents to those patients with the unique subtypes. So it was sort of an interesting proof of concept study. It wasn't a very large study, but what they did is they took patients with diffuse large B-cell lymphoma and randomized them in a 1-to-1 fashion to either standard R-CHOP or based on their genetic profile. Now, they didn't use the same type of genetic profiling as was done to create that schema that I showed you with the different subtypes, but they used a rather simplified version, picking out the perhaps main genetic abnormalities of each of the distinct subtypes. So a bit of a rudimentary enrichment of the subtypes. And what they did was they added on a novel agent based on the subtype that the patient exhibited. And when they looked head to head at the comparison between the group that was randomized only to R-CHOP versus the group that, based on their subtype, was allocated to R-CHOP plus a novel agent, and there were a series of novel agents that included ibrutinib, lenalidomide, and various other agents, what they demonstrated was that for progression-free survival, the group getting the novel agent actually did better and had a remarkably favorable outcome. So is this definitive? No, of course not. It's a very small trial with just 60 patients in each arm, and of course, using a variety of therapies. But I think it was an intriguing proof of concept that if we can actually measure the biology and target novel agents more in a more specific way to that biology, we might actually make true progress. So I think that right now, unfortunately, the classification regarding the more intricate subtypes, currently there is no validated clinical tool that would allow us to, on our own clinic, segregate patients into these subtypes. But this is a very active area of research, and I expect that within the next series of clinical trials, we will see various tools that are being developed, tested prospectively, so that hopefully one day we can actually use these validated tools in our own clinic and perhaps make treatment better. So what about relapsed refractory diffuse large B-cell lymphoma? Well, we know that as clinicians, this is one of the most challenging things that we have to treat. We've had a series of options available in the past. And in my own patients, I generally try and think, do I have anything that will still provide that patient with a chance of cure with a secondary go-around of treatment? Historically, this has relied on salvage cisplatin-based therapy and an autologous stem cell transplant to give the patient that best chance of cure. We know not all patients are appropriate for this because of age or comorbidities. So if patients are young enough and well enough, they still go down that route. It's the standard of care. Although we've heard rumors that CAR T-cell therapy, some of the trials that have compared against salvage autologous stem cell transplant may be testing this concept in the future. So we look forward to seeing that data. But CAR T-cell therapy, of course, is also a relatively novel approach that has emerged. It currently is approved for patients who have received at least 2 lines of therapy and were generally thought not to be curable. And data has emerged demonstrating really significant benefit, particularly for a proportion of patients that have exhibited very durable responses and may offer a chance of cure for some patients. Short of that, what we've really relied on for years has been palliative chemotherapy, so using either single agent or multi-agent chemotherapy with little chance of curing the patient and unfortunately little chance of providing durable control. Palliative radiation therapy, rarely an effective treatment, as these patients generally have widespread systemic disease. Allogeneic transplant, I'd have to say, is rarely an option in my own clinic. Many of these patients are older, and allogeneic transplant is often not feasible based on the pace of aggressive diffuse large B-cell lymphoma. So we're excited to see that there are numerous novel agents that are now emerging that are giving us newer options for these patients. So I already mentioned CAR T-cell therapy as being really probably a game changer for diffuse large B-cell lymphoma in patients who can access it. We do understand that it's a treatment that is highly costly and relegated to specialty centers. In my own center, we still have difficulty with access and are struggling to create a program that meets all of our patients' needs. But it's really shown that with longer and longer follow-up from some of the pivotal trials, we're starting to realize that some of these patients have exhibited such durable control that we think it may be curative for a fraction of patients that probably sits around the 35% range of patients, although, in a very select group of patients, certainly that made it into these initial pivotal trials. But more importantly, we're starting to see novel agents that can be delivered more universally in the clinic that are showing the capacity to overcome chemotherapy-resistant disease and provide patients with durable benefit. So the first treatment that was approved for relapsed refractory diffuse large B-cell lymphoma was polatuzumab vedotin, which is an anti-CD79B drug conjugate. So this drug targets CD79B, which is pretty much universally present on all cases of diffuse large B-cell lymphoma. It is attached to an MMAE toxin, so monomethyl auristatin E, which is a microtubule disruptor. So when it attaches to CD79B, it gets absorbed into the cell, gets dissociated, and the microtubule toxin leads to cellular apoptosis. So recently we saw updated data of the pivotal trial that actually earned this drug its approval. So the GO29365 study had an initial safety run-in of polatuzumab vedotin, and in this trial, it was actually combined with bendamustine and rituximab in a triple combination therapy. This study enrolled patients with diffuse large B-cell lymphoma that were relapsed or refractory, who had received at least one prior line of therapy and were considered to be transplant ineligible. So after an initial safety run-in, there was a randomized phase 2 portion that compared patients who received Pola-BR versus BR alone. At this point, we've got extended median follow-up of those patients of over 4 years. And then subsequently, there was an additional extension cohort of 106 patients that received only Pola-BR, so in a one-arm, single-arm fashion, and the median follow-up of that arm at the time of this reporting was 15 months. So Pola-BR is a finite treatment. It gets given as one dose of polatuzumab added to each cycle of BR every 3 weeks for up to 6 cycles of therapy. In the initial pivotal trial that earned it its approval, that was the randomized phase 2 portion that randomized 40 patients in each arm. And we can see that the primary endpoint of PET-CR rate was statistically higher in patients receiving the Pola-BR, so 40% CR rate compared to 18%. And this translated to a significant improvement in overall survival with a median of 12.4 months versus 4.7 months. So with the extension cohort, so the additional 106 patients treated in the single-arm fashion, we now have a pooled cohort of 152 patients. You can see the patient characteristics listed on the right side of this curve. So the median age was 69, but there were patients that were as old as 94 years that participated in that trial. The median number of prior lines of therapy was 2, although patients had received even up to 7 prior lines of therapy. And I think most importantly, when you look at this cohort, this was a highly refractory group of patients. So more than 60%, in fact, 64% of patients had primary refractory disease, and 76% were refractory to their last prior line of therapy. So this is a group of patients I would not expect to do very well with standard palliative chemotherapy. Looking at the wider group of patients, you can see that the response rates varied based on patient characteristics, with patients who had received only 1 prior line of therapy and those who were non-refractory or non-primary refractory having remarkably high response rates. But patients who had received multiple lines or were refractory actually did quite well as well. With, you can see here, the best overall response rate ranged from 94% down to 40%. What I think is quite striking is of the patients that respond, the majority of them actually had a very significant response, achieving a complete remission rather than a partial remission, because the complete remission are those bars there that you can see in green. So if you're going to respond, there's a good chance that you're going to have an excellent response and a complete response. So with extended follow-up in the initial randomized cohort, we see that the median progression-free survival is 9.2 months, and the median overall survival was 12.4 months. And importantly, there's definitely a tail on this curve where a proportion of the patients still have not relapsed. So at 2 years, 38%, or I should say 28% of patients remained progression-free and 38% of patients remained alive. And the outcome in the extended cohort is quite comparable, where we see the median overall survival of also 12.5 months. In terms of safety, with the extended follow-up, there were no new safety signals that were noted. So the primary toxicities related to cytopenias. In terms of peripheral neuropathy, it was largely low grade, so very few patients had higher grade peripheral neuropathy, and the peripheral neuropathy with this finite therapy was actually very manageable and reversible. The next agent that was approved in diffuse large B-cell lymphoma was selinexor. So this is an oral drug that actually targets a unique epitope called XPO1. Sorry, maybe I'll go back here. So XPO1 is a nuclear export protein that moves proteins in and out of the nucleus. And if you target it and block XPO1, which is what selinexor does, you actually have a buildup of proteins within the nucleus that lead to apoptosis. So in this pivotal trial that earned this drug its approval, it was a single-arm phase 2 study that enrolled patients with relapsed or refractory diffuse large B-cell lymphoma who were not eligible for transplant. They had to have between 2 to 5 prior lines of treatment. Interestingly, they had to have quite a long washout period, so they could not have received treatment in the last 60 to 98 days, which means that perhaps some of the most aggressive biology patients didn't make it in onto this trial, but nonetheless, it was an oral agent that was given twice weekly indefinitely until progression or intolerance. So this trial enrolled 127 patients, and the primary endpoint was response rate, when you can see here that the overall response rate was somewhat modest at 28%, and the CR rate was only 10%. The median progression-free survival was only 2.6%, but if you actually responded, patients had a duration of response of 9.3 months. So I think a bit of a modest agent, but again, easy to administer oral treatment. It did have generally low-grade toxicity. So the highest grade toxicity is related to thrombocytopenia, which might make it a little bit hard to combine in the future studies that are looking at combining it with other agents. But The primary toxicities were mainly constitutional, so nausea, fatigue, gastrointestinal symptoms. And I think for patients to be able to tolerate this well and have a good quality of life, there probably will be some supportive management that will be necessary. The next drug that I think is actually earning a lot of interest recently is tafasitamab. So this drug has also been approved based on a trial that combined it with lenalidomide. So tafasitamab is a anti-CD19 monoclonal antibody. So monoclonal antibody just like rituximab, but in this case it targets CD19, not CD20. And similar to rituximab, it's designed to bring in an immune response, including antibody-dependent cellular cytotoxicity, as well as direct cell death. And in this trial, it was combined with the immunomodulator lenalidomide that has the capacity to potentially expand T and NK cell function. So together, they may actually synergize to lead to an immune benefit. So in the ALMIND study, which was the pivotal trial that earned this combination its approval, patients with relapsed refractory diffuse large B-cell lymphoma who had received 1 to 3 prior lines of treatment, but who were not primary refractory were eligible, and they had to be, of course, non-transplant eligible. So this trial initially excluded primary refractory patients. However, there was an amendment where later some patients who were primary refractory were allowed. Tafasitamab was given weekly for the first 3 months, so it's a somewhat effortful at the beginning, but then subsequently for cycles 4 to 12, it was given twice a month. And then beyond that continues twice monthly to progression. The lenalidomide was only given for a year at standard lenalidomide dosing. So these are the baseline characteristics of the patient. It was a modest-sized trial, including 81 patients in total, but patients had received a median of 2 prior lines of therapy. Of course, because they initially excluded the primary refractory patients, only under 20% of patients had primary refractory disease, and only 44% were refractory to their last prior line of therapy. But when this result was first reported, with a median follow-up of 17 months, the overall response rate was quite significant at 60%, with 43% of patients achieving a complete response, and the median progression-free survival was 12.1 months. What we just saw presented at ICML was longer-term follow-up of this trial. So now with 34 months of follow-up, so double the follow-up that was available at the time of the initial publication, we can see here that the overall response rate is actually a little bit higher. In fact, it is 47%. And importantly now, the median progression-free survival, probably a little bit more sound because we've got longer follow-up, but the median progression-free survival for all patients in the trial was 11.6 months, and the median overall survival was 33.5 months. And we can see here, if you look at patients based on whether or not they received 1 prior line of therapy, which was half the patients, versus more than 1 prior line of therapy, patients receiving only 1 prior line of therapy did better, but the median progression-free survival is actually almost 24 months in these patients, and the median overall survival, 46 months. So this is the duration of response curve. If you are lucky to be one of the responding patients, those patients did quite well with a median duration of response of almost 44 months. And if you had a complete remission, the median duration of response was not yet reached and was quite lengthy. For progression-free survival, similarly looking at all patients, the median progression-free survival for all patients was 11.6 months, but if you are lucky to achieve a complete remission, the median progression-free survival has not been reached, and you can see is actually quite high out beyond the 3-year mark. And overall survival, similarly, if you achieved a complete remission, those patients are doing remarkably well, with the median overall survival also impressive at 34 months. In terms of toxicity, this slide divides toxicity up based on the first 12 months of therapy and beyond. So it's in the first 12 months of therapy that patients are receiving the combination of lenalidomide and tafasitamab, and subsequently they just go on to receive the tafasitamab indefinitely. And toxicities, I'd say, are quite similar to what we'd expect with lenalidomide. So we've got cytopenias sort of heading up at the top of the list, as well as gastrointestinal symptoms with diarrhea and rash. But once patients get beyond that first 12 months, the toxicities with tafasitamab are relatively minor, with very few higher grade toxicities being mainly the neutropenia. So this is, I think, a combination gleaming a lot of interest, but we must keep in mind that it was a relatively good profile of patients, and I think we want to see more data emerge on patients that have more refractory disease. Also keep in mind that tafasitamab targets CD19. We know that that's the same target as CAR T cell therapy. So if this combination is going to be used, I think that we still don't have a lot of data about the safety and feasibility of giving it ahead of CAR T cell therapy. So I think most people who have access to CAR T cell therapy would probably not be utilizing it ahead of CAR T cell therapy for concerns that it may compete against the same target. But I'm sure that we'll, out of real world experience, be learning more about the feasibility of giving it ahead of CAR T cell therapy. We just don't have that data right now. So the next drug that has recently earned approval is called loncastuximab tesirine, which I'll refer to as Lonca. This is a drug that also targets CD19 as its target. So it's an anti-CD19 antibody drug conjugate. Here it's conjugated to a PBD dimer that actually conjugates and intercalates and cross-links DNA. So when this drug targets CD19 and gets absorbed into the cell, the PBD dimer gets dissociated, cross-links with DNA, and leads to apoptosis. So the pivotal trial that earned this drug its approval was a phase 2 study in patients with relapsed refractory DLBCL who were unsuitable for transplant, who had at least 2 prior lines of systemic therapy. The drug is given intravenously over 30 minutes, initially every 3 weeks at a higher dose for the first 2 cycles, and then subsequently at a lower dose. And it's given every 3 weeks for a full year, and then given every 3 months for up to 3 years, but patients were allowed to continue indefinitely if they were responding. So this single-arm trial enrolled 145 patients. The majority of patients had diffuse large B-cell lymphoma, but there were other high-grade B-cell lymphomas and primary mediastinal B-cell lymphomas included as well. Patients had had a median of 3 prior lines of therapy. So compared to the other 2 trials or the other 3 trials that I showed you, this was a much higher pre-treated patient population. And also quite refractory, though, that looking at response to their last line of therapy, about 60% of them were considered refractory. I would say the efficacy actually was quite impressive given the number of prior lines of therapy patients received, but was generally modest with an overall response rate of 48% and a complete response rate of just under 25%. The median progression-free survival was 5.09 months, and the median overall survival was just over 9 months. So again, I think based on the number of prior treatments, this was actually quite reasonable. And in terms of its safety, I'd say that the toxicities seen were quite similar to what we'd expect with antibody drug conjugates, where cytopenias are generally the primary toxicity that we see. So neutropenia, thrombocytopenia, and anemia. However, there was a transaminitis that was observed that was largely transient. So finally, I'll end with an additional trial that was presented at ICML. So I think many of us are excited about the novel treatment, novel class of treatments that will soon be emerging, likely called bispecific antibodies. And we saw updated at ICML data from the glofitamab study, which is one of the bispecific antibodies that's probably furthest along in development. So glofitamab is a T-cell engaging bispecific antibody. It has a 2-to-1 format. So it has basically the capacity to bind to CD20 twice on the same, using the same molecule, and as well simultaneously binds to CD3. So this bispecific antibody is aimed to bind to CD20 on the B cells and CD3 on T cells, with the goal of bringing together the T cells to the B cells so that it can induce a T cell immune response, so T cell activation and proliferation. So what was presented at ICML was update of an ongoing phase 1/2 study. The study has evolved over time, looking at optimal dosing. So not only have they been sort of titrating the dose, trying to find the maximum tolerated and most effective dose, but also trying to find the safest way to administer it. So initially it had been given in a flat dosing, so starting with one dose right from the beginning, although they were seeing perhaps a higher rate of CRS or cytokine release syndrome than they were hoping to, and it was preventing them from escalating the dose too high. So they switched to a step-up dosing model where in the first 2 doses, patients received a slightly lower dose and then went on to receive the higher dose from dose 3 onward. So again, a step-up dosing where the data presented in this update included 2 different dosing arms. So step up with the 2.5 and 10 milligram dosing, and then either going on to receive 16 milligrams or 30 milligram dosing level. Again, this is just the treatment schema, again, demonstrating the step-up dosing that was administered. This drug ultimately, after the initial run-in of the step-up dosing, is given on an every 3-week cycle for up to 12 doses. The key inclusion criteria included patients who had received at least 1 prior line of therapy. And the primary objective was really safety and tolerability. So in total, we had 52 patients included and reported on in this trial. So the median age of patients was 68. You can see here that this was a heavily pretreated population of patients, so a median of 3 prior lines of therapy. They were also quite highly refractory, so about 85% of them were refractory to any prior line of therapy, and 76% were refractory to their prior line of therapy. There were a variety of histologies that were included in this trial. So about half of the patients had aggressive non-Hodgkin lymphomas, and just under half of the patients had indolent non-Hodgkin lymphoma. And of the aggressive non-Hodgkin lymphomas, about 20% of patients in this cohort had diffuse large B-cell lymphoma. So here we see the results. So this is looking at the response rate, and here the results are divided based on whether or not the patients had aggressive or indolent non-Hodgkin lymphoma. We're going to focus on the aggressive arm because we're discussing diffuse large B-cell lymphoma today. But of the patients in the aggressive cohort, we can see that there was quite a significant response rate. So looking at all patients, the response rate was 64%. And we actually looked at the higher dose cohort, the response rate was up to 78%. And I think intriguing as well, if you did respond, you were highly likely to have a very good response. So the green bars represented the complete responses. And so really, I think very similar to what we have seen with the polatuzumab BR fraction, similar to what we see with CAR T cells, the responders, patients either divide themselves into responders or non-responders, and the responders actually have quite significant benefit with a high likelihood of complete remission. And in terms of, here you can see the waterfall plot looking at the degree of response. And again, focusing on the left side of the curve for patients with aggressive non-Hodgkin lymphoma, we can see quite an impressive waterfall plot, regardless of the kind of aggressive non-Hodgkin lymphomas the patient had. Patients in diffuse large B-cell lymphomas are represented in the green bars on this slide. And looking at durability of benefit, so for patients who actually responded and actually received a complete response, so those who received a complete metabolic response, patients with the aggressive lymphoma here are reflected in the blue line on this curve. But you can see here that with follow-up that is now going out to still relatively short follow-up, we must admit, but follow-up about 6 months for the aggressive arm, you can see that the responders are actually proving to be quite durable. And what about toxicities? Well, I think that we all recognize that this type of immunotherapy is associated with some unique toxicities that we don't generally see with chemotherapy. The primary toxicity relates to cytokine release syndrome. So this is generally a constellation of symptoms that occur primarily around the first cycle of treatment and then are no longer likely to occur. So similar to the infusion-related reactions that we see and manage with monoclonal antibodies, CRS generally represents kind of a constellation of symptoms that, in my mind, are generally often a more extreme version of infusion-related reactions where patients can exhibit rigors and fevers and hemodynamic instability if it gets to be quite severe. So it's something that does need to be monitored for. In the majority of patients, however, the cytokine release syndrome is generally just low grade and manageable and likely would not require hospitalization, but in a small proportion of patients, higher grade CRS can be seen, in which case, it needs to be monitored for. And if it does escalate, generally these patients are treated with tocilizumab as a way of suppressing the CRS. So it is a manageable type of toxicity. Importantly, the neuropathy that is a concerning toxicity for CAR T cell therapy, an alternate form of immunotherapy, is not seen with these bispecific monoclonal antibodies. Also, neutropenia and cytopenias is probably the next most common toxicity that we see. But again, these are manageable toxicities. So just to summarize, I think it really is an exciting time for managing patients with diffuse large B-cell lymphoma. We're starting to see data emerging from the novel agent trials, and we're starting to see novel agents actually approved in this setting. So if you can imagine, we went, I would say, 3 years ago with nothing more than palliative chemoimmunotherapy to offer patients once they had multiply relapsed disease and were not transplant eligible or had failed transplant, to now a setting where we've had multiple novel therapies, in fact, 4 novel therapies that have been already approved in some jurisdictions in the world, and likely more novel therapies like the bispecifics will likely emerge. But I think the most exciting part is that we now have treatments to offer our patients that are actually showing the ability to overcome chemotherapy resistance and to provide patients with durable disease control. I think we certainly need longer follow-up to understand whether or not any of these treatments will provide patients with a curative option. But I think it's intriguing to see that some of these patients who achieve complete remissions are maintaining durable complete remissions with fairly lengthy follow-up. How are we going to optimize treatment in the frontline setting? I think this still remains a challenge. There is a trial reporting out sooner called the Polarix trial, which will look at introducing polatuzumab into the frontline setting. And that trial has actually put out a statement that it has met its primary endpoint. So I think we all look forward to seeing the data from that trial shortly. But in the meantime, looking at the next set of generation of trials, I think we will need to start using the biology, the distinct biology that we've learned from emerging data that demonstrates that diffuse large B-cell lymphoma goes well beyond 2 subtypes, and we'll need to have validated tools that allow us to measure that biology in our own patients so that we can capitalize and optimize bringing in novel therapies for the right patients. With this tremendous wealth of riches, I think the next big question is going to be, how do we sequence all of these novel agents to make sure that we're optimizing management? I think that, again, I'd like to think that in the future we'll be using patient biology to pick the right next drug. Although I think we're a little bit far from that right now. We need to get more data. And hopefully that will emerge from maybe real world studies or sort of the next set of correlative studies that we see presented out of some of these initial trials. But I think in my own clinic, if I had access to several of these options, I certainly would be trying to take into account what the goals of therapy are for my patient. So, and then, exploring the data and considering what the comparative efficacies and toxicities are, because clearly we don't yet have trials that have compared these agents head to head. So it's hard to compare across trials because, as we saw, these patient populations are quite different. Some of them were highly refractory, some less refractory. So you can't just take the benefit that we see at face value and compare it across trials. But certainly when I'm picking an agent, I would consider the efficacy and toxicity that's been reported, and then think about the patient and their comorbidities and their age, and try to match up what might be feasible therapy for that patient. And of course, some of these treatments are finite. Some of them are intravenous and require repeated administration. Some of them go on indefinitely. Some are oral therapies. So I think it's going to be important in the future to take into account patient preferences as well. I thank you for your attention.
Well, we thank Dr. Lauria. she was to travel from Vancouver to Chicago, and the airline messed up her travel schedule, as a result of which, exactly at the time of this webinar, her timing of travel got shifted. So she pre-recorded this lecture with the help of Mice Ideas just before travel and sent it to us. As a result of this, now she's traveling and she's not available to us for question and answer session. We're grateful to her for doing this extraordinary efforts of putting this together and delivering this talk to us, updating us with all the novel molecules and telling us what lies in store for the future of DLBCL, especially for those 30-40% of patients who are not cured with R-CHOP. With that, this 7 days marathon comes to an end, and I don't have much to say except thanks to all of you, and to two people, one, Dr. Manoj and the team from INTAS, and second, Mr. Rajesh Kalpesh and Nirav and the team from Mice Ideas. So over to Dr. Manoj now for last official thanks on behalf of this update on lymphomas.
Thank you so much, sir. 21 international speaker, more than 21 long hours of lectures and interactions has been a lot meaningful. And the last was lecture of Dr. Laurie was saved to the last. You say best is always at the last, and they were really, really insightful. I must thank you personally and professionally for so much of effort. I mean, it was not possible. Those 21 international speakers are with their own original research work are extremely tough to get. Only you could pull it off for more than 15 countries who would like to thank you. And those hematologists, I'm sure, would like to thank you, sir. So thank you indeed. Our chief guest today, Dr. Sharad Damodar, for those pearls of wisdom. Two other international speakers today, Dr. Stephen and Dr. Loretta. Both of them were quite insightful. And our expert panelists from today, Dr. Jay Chandran, Dr. Anant, Dr. Dipankar Bhattacharya, Dr. Jatin Sareen, Dr. Rahul Arora, Dr. Shilpa Bhatia, Dr. Roshni Pandey, Dr. Ankita Sen, Dr. Aditi, and Dr. Ankur Mittal. And sir, all these delegates who have joined in from more than 15 countries today, thank you with the bottom of our heart. I know from tomorrow morning, the treatment of lymphoma would be much more enriching and insightful. We thank all the delegates who have logged in for last 7 days. Wish you best wishes, and may the third wave doesn't come and we meet in physical. Of course, the webinars would continue. Thank you so very much.
Thank you, Dr. Manoj. Thanks to all the faculty present over here. And I must inform you that after each and every lecture, next day, there has been an email from our faculty appreciating the knowledge which Indian faculty possessed and the quality of questions which were asked by them and put up by the delegates in the question box. They were amazed, and their conclusion was that probably you didn't need any education. All of you had such vast knowledge to ask such interesting and poking questions. So that's a feather in your cap. All of you are on par with the international faculty, and this was unanimous opinion from virtually all the faculty members, and they would be loving to come back and speak to us. They enjoyed it every bit. So once again, thank you, Manoj. Thanks, faculty. Thanks to Mice Ideas for an extremely smooth 7 days marathon webinars. Thank you, and good night to everybody. Enjoy with your families.
Thank you, sir.
Thank you.